Good morning. How are you? Oh, can't. Okay.
Hi.
Hi. I don't know how the connection's gonna work, but we will see what happens. I'll stay on for the chat and the beginning.
Okay,
Yeah.
that's great. I'm gonna put up the sponsor slide. I'll share my screen. So when all the participants come in, I make them all host
When the presenters, yes.
presenters. Yeah.
Yeah.
Okay.
Yeah. So you only it's just the presenters and then everybody else you just leave alone.
Awesome.
Yeah.
All right. Well, I'm gonna share my screen and put up that slide. And thanks so much.
Oh, sure. It's an adventure. You'll see like blurry Josie walking around behind me as she's dismantling her apartment.
Oh. All right. Well, thanks so much.
Oh, sure. Good morning, everybody. While we're waiting for other people to join, if you wanted to go ahead and put in the chat your favorite summer activity and just say hi and good morning, everybody. We're going to be using the chat function today for questions and answers through the Q&A through the presentation. So if you want to just get familiar, I know most of you are probably spending more time on Zoom than you'd like, but the chat button at the bottom, you can go ahead and type something in and say hello to the entire group. So we know who's here and what your favorite summer activity is. And we're going to get started at 9. Thanks. Are putting their favorite summer activity in the chat this morning. So we can, what everybody likes to do. Lots of beaching right now.
That's me.
And I did mention that the question and any Q&A today is going to be through the chat. So that way you keep an eye on it. Presentations.
Probably should have had some music. If I stop video for myself, will I stop sharing the screen?
I'm sorry, say that again.
If I stop my video, like, so you don't see me, will it stop sharing screen?
You, no, your screen should still be shared. Try it. Put yourself on. Yeah, we still see your screen.
Okay, excellent. Thank you. And you can't see the chat box up on the screen?
No, you can only see the chat box on your own screen if you have it up. So if you
Perfect.
right click on, if you just click on it, you can see it Like right now, it's on the middle of my screen and you don't see it over me. So,
Okay.
oh, Melanie, do you have any good book recommendations? I'm always looking for new books to read. I think we've had a couple new people join us for putting our favorite summer activities in the chat, just to say hello and good morning. Everybody is on mute when they come in, so we're just going to leave that and then just work through the Q&A through the chat for the day. So any questions, any problems you're having, technology, any questions you have, just go ahead and put those right in the chat, and also what you like to do in the summer. Good morning to those of you that have just joined. We got a little distracted. We started with favorite summer activities in the chat, and now we're talking about driving through West Virginia and favorite books. So say hello in the chat, and throughout the morning, we're going to be using the chat for the Q&A. So I'm sure you're familiar with Zoom, but just to familiarize yourself, just go ahead and say hello and tell us a favorite summer activity or a favorite book. And thank you for being here today. Are they like good? That's great. Are they like cleaning people? Okay, we're going to get started in about 5 minutes. I don't think we've had anybody new join recently, but we've got some great book recommendations and also fun things that people did in the summer or enjoy doing in the summer. Some great trip ideas. So thank you again for joining us. Good morning. We're getting ready to start. I just wanted to go ahead and just remind you that if you're new, let you know that we will be starting in a couple minutes. Thanks, Kira, for putting that in the chat. But if you could put your favorite summer activity, we did get a little distracted with books, into the chat just to say hello and let us know you're here and who you are. And then throughout the morning, any of the Q&A is going to be happening through the chat. So if you have any questions or concerns or need more information, go ahead and put that in the chat. And at some point, either through the presentation or after the presentation, we'll address those. Somebody will be keeping an eye on them throughout. So go ahead and put any information in there. And thanks again for joining us this morning.
All right, everyone. I think we're going to go ahead and get started. This is our first annual Mid-Atlantic Seizure Smart Conference, and I just wanted to thank everyone for joining today. We have a really great lineup of speakers for you today. As Carrie mentioned, if you have any questions, please put them in the chat box. We'll look at those questions at the end of each presentation, and if time allows, we'll try to get through as many questions as we can. Feel free, if you need to take a break, go ahead and do that. Come and go as you wish. We will have a break at 11 a.m., a 15-minute break, but again, please feel free to come and go as needed. I did want to thank our sponsors, our very generous sponsors, who helped us to be able to put this on for you. Our presenting sponsor was Synovian. Our other sponsors, Azi, Jazz Pharmaceuticals, LivaNova VNS, Neurelis, SK Life Science, UCB, and Ultragenyx. So we appreciate their support very much. So for our first session today, we're going to hear a little bit from Dr. Greg Krause. And Dr. Krause, he's a professor of neurology at Johns Hopkins University. Unfortunately, he was stuck out of the country, and so we videotaped his part of the presentation, and I'll be playing that for you today. And he does say his apologies for not being able to join us in person. So again, Dr. Krause, he is a professor of neurology at Johns Hopkins University. He is also the co-inventor of the Epi Watch for seizure detection. So today, his presentation is talking a little bit about seizure detection and suit-up mitigation. I hope you enjoy.
Morning. Thanks for allowing me to do recording. Sorry that I was waiting today, but very happy to present this talk and go over things about them monitoring. And so for the past several years, but what I want to do is review briefly the seizure detection devices and talk a bit about what are the risks to death, and then how can you potentially use seizure detection and alerting perform seizure monitoring. That's helpful for them.
Hey, Kira, I don't think we can hear Dr. Krause.
like the physician to be involved in adjusting the device, and they would like to participate in the study. But what they don't want are conspicuous kind of devices like a half.
I think right before you share your screen, there should have been like a checkbox to share your computer's audio. I'm not sure if you saw that little box there.
All right, we are going to stop for a moment. All right, we are going to go back so that you all can hear from the beginning. And if someone can just, Carrie, if you can let me know if we can hear.
Watch seizure detection app that can detect.
He's just really hard to hear. I have my volume turned all the way up. I don't know whether there's a way to add captions to him,
Reduce risks of sudden.
but I know everybody else was having trouble too.
What I want to do is
Yeah,
review briefly
I've
the
had to
seizure
turn up.
detection using mobile devices, and then talk a bit.
Yeah, it's way better though.
SUDEP,
Okay.
and then how can you potentially use seizure detection and alerting and perform seizure first aid to best help people with epilepsy. And
It's great here. Thank you.
so here's my disclosures. I'm a co-inventor of a research app to detect seizures. And here's what this is about. This is a patient of mine who died of SUDEP recently. And I have several patients a year who suddenly die after following tonic-clonic seizures. And so this was a 30-year-old male who had very uncontrolled epilepsy, 4 seizures per month, including 1 tonic-clonic seizure. He had not responded to 8 different seizure medications. And then he was on a new medicine that often makes people seizure-free called cenobamate, and he became seizure-free. And then as part of his new life, he was moving from Philadelphia to Washington, and he packed up his medications with his shipping materials. And he missed 2 days of his medications. And then he was in a shower in his new apartment, and he was heard to collapse by his roommate, and he found him dead in his bathtub. And his autopsy only showed pulmonary congestion, no other cause for his death. So the presumption was he had had very uncontrolled seizures, missed his medicines for 2 days, had a seizure, and suffered SUDEP, sudden unexpected death in epilepsy. His mother was devastated. She drove down. We went over the autopsy together, but we have to deal with this sort of thing. And the poor family members have to deal with this several times a year in my clinic. And so this is devastating for the families, and obviously it's something we want to prevent. And the key is probably to prevent tonic-clonic seizures and to detect them and to support people during their seizures. And so there's a lot of use for seizure detectors and support features that are part of these apps. They can increase independence where people can go out more and their families aren't worried about them getting injured or having a seizure in public. It potentially can reduce risk for SUDEP by detecting seizures to allow seizure first aid to be given. It also can be used to screen for seizures and log them, and to manage treatments and screen for things like drug side effects and track how people are doing so they can communicate with their doctors. But when you survey patients about what they want with seizure detectors, what they want are something like a wristband that's inconspicuous, or intelligent clothing that can detect seizures. They want the seizures to be registered in the device. They would like seizure prediction, but I can tell you so far only intracranial electrodes have provided seizure prediction. So the current devices are seizure detectors that detect seizures that are starting, but they're not predicting seizures that are coming up in 30 minutes, so you can get to safety. They like there to be emergency alerts to families members and caregivers so they can help the person with the seizures. They like the physician to be involved in adjusting the device, and they would like to participate in studies. But what they don't want are conspicuous kind of devices like a hat or cap device, patched or glued or implanted electrodes. And they actually don't want direct MD notifications. They want to kind of have control of their lives, tracking their seizures, and then work with the doctor. So this is what patients say in surveys. So don't try to drive with a seizure detector. Now, there's a lot of different seizure detectors that have been produced or are in development. The VNS device has a fairly sensitive seizure detector, but it over detects, so it detects several seizures an hour and activates the VNS based on heart rate changes. There's a convulsive movement detector called Smart Monitor. There's a EMG seizure detector that's very effective, but unfortunately the company has folded. There's an electrodermal movement monitoring detector called Embrace that you can get now and order with a subscription or a prescription. And then our EpiWatch uses heart rate and movement and responsiveness to detect seizures. And it's in late development. It's in an FDA study. Sorry, my keyboard's not working. So our EpiWatch research app is a detector, a seizure detector built into the Apple Watch. And it monitors heart rate and movements and detects tonic-clonic seizures and alerts caregivers. One nice thing of the Apple Watch is this little mini computer. So after the seizure, we test recovery. We give people memory tests. And 10 minutes after the seizure, if they've recovered, we give them a survey. Did you miss your medicine? Had menses occurred? Have you drunk a lot of alcohol? So we can kind of look at seizure triggers. And it also provides a lot of disease management, like screening for drug side effects. And we've had participants all over the country through networking. They volunteered for research. We found a lot of things about epilepsy, like with our Apple Watch. When people have seizures, we query them, and these are the most common triggers. About a quarter of people report a trigger right before their seizures, mostly stress, often linked to sleep deprivation or menses or overexertion. So these are the sort of things that you can pick up with a device that can monitor seizures. Now, the reason we need this device is to try to prevent serious harm during seizures. And this shows the cumulative risk of sudden unexpected death from the age of epilepsy onset. So it shows at 1, 15, and 30 years, what's your lifetime risk, your cumulative risk of SUDEP? And you can see it really adds up. So even though a person with uncontrolled seizures may only have, say, 1 in 50, 1 in 100 per year's risk of SUDEP, over many years that starts to add up and plateau at around 5 to 8%, depending on how early the seizure started in an individual. But you can see there's a significant risk of SUDEP over time in people with persisting seizures. And this is the definition, the formal definition of sudden unexpected death, but it's the sudden unexpected witnessed or unwitnessed non-traumatic, non-drowning death in patients with epilepsy. So basically no clear causes like asphyxiation or drowning. There's no with or without evidence of a seizure, but the majority of people actually do have documented seizures right before SUDEP. Status epilepticus is not included in the definition of SUDEP because it itself is suspected to harm persons. The postmortem exam does not reveal a structural toxicologic cause for death. And then there's possible SUDEP, which is a majority of patients where you don't have autopsy data. And then near SUDEP, where someone, say, asphyxiates or their heart stops following a seizure, but they're resuscitated successfully, and that can occur. Now, the distribution of SUDEP is really spread across the lifespan, but is highest in the mid-adult years, as you can see on the right. And then the risk of SUDEP is really related to the severity of epilepsy. So if you just look at, general population risks of people with epilepsy, the risk of SUDEP is low. These are the annual rates per 1,000 people with epilepsy. But if you're in an epilepsy clinic, your risks are higher because you often have been referred in because your seizures are a little worse. Residential care patients, high risk. Refractory epilepsy, even higher. And those who have very severe epilepsy referred for possible surgery or VNS, they have very high risk for SUDEP. Now, here's a key slide. It shows the risks of SUDEP based on whether you share a bedroom with someone else and whether you have a history of tonic-clonic or no tonic-clonic seizures. And so what that means, if you cross these risks, if you actually sleep with someone else or have baby monitoring and you don't have tonic-clonic seizures, you may just have focal unaware seizures, the risk of SUDEP is background. It's not increased at all. But if you have both risk factors present, you have a history of tonic-clonic seizures, and you sleep alone, the risk of SUDEP goes way up. It's 27-fold increased. And so if you have tonic-clonic seizures and you have unwitnessed seizures, there's a very high risk of SUDEP. And that gives a big clue about what's causing SUDEP and what we might need to do to prevent SUDEP. And so there's a lot of large autopsy series from several different countries looking at what are the risks of SUDEP, like when you study it very carefully. And this is an Iceland study where they looked at all the people in Iceland and they found 37 individuals who had had SUDEP. And so they studied them carefully. And first they found that most of them occurred at home and most were unobserved. Most of them were found in the morning, suggesting that they had SUDEP occurring during sleep. And 29 had their head positions described in the autopsy reports, and 76% had been found face down. So basically, sleeping face down and having a tonic-clonic seizure, we think is a high risk factor for encountering SUDEP. And so the overall risk is varied. It's a little higher for men than for women, but the big risk is unobserved nocturnal seizures, particularly in the prone position. So 84% had a history of tonic-clonic seizures, and over half of them had had 3 or more tonic-clonic seizures in the last year before death. So the big risk for SUDEP is tonic-clonic seizures, particularly in sleep when face down. And so the North American SUDEP Registry looked at these types of factors and recently published, findings in people who had passed away with SUDEP. And some people had not taken their medicine before the SUDEP. It's unclear. Some of them may have actually had SUDEP causing them to miss their doses. But 70% were asleep at the time of death. And the minority were sharing a room during sleep. And 69% were found in a prone position, and 74% had clear evidence of a preceding seizure. And that means like signs of a bit tongue or eye vein injuries from increased pressure from a convulsion. And so sleeping with a history of tonic-clonic seizures, face down, alone, those are the major risks for SUDEP. Now, this has been studied very precisely in seizure units. This is called the Mortimus study. And this was 11 patients who, during seizure monitoring at EMUs all over the world, had sudden death. And so these were patients who typically had a convulsion, often at night. The staff just weren't paying attention. Maybe they were face down, wedged in their bed. And so what this shows is what happened to them prior to the SUDEP. And what was seen was most of them had a pause in breathing during the seizure and at the end of the seizure. They often had slowdown in their heart rate, bradycardia, that's the lavender. And then that was followed by terminal asystole, where the heart stopped.
And so basically people have respiratory arrest, they'll get bradycardia, which means a slowdown in the heart rate, and then the heart will stop, sometimes with a terminal tachycardia. But this is a typical cardiac arrest pattern where people are probably having a respiratory arrest with apnea. That means you're not breathing. And then the lack of oxygen is triggering the terminal apnea and the cardiac arrest. And so this was demonstrated in a number of patients using video EEG in this international study. Now we think generally there's two mechanisms for SUDEP. The vast majority have this postictal kind of mechanism where they'll have a seizure, which we call in medicine the ictal period. And then if it's a convulsive seizure, which is the CS there in the middle of the slide, then in the postictal phase, they have decreased breathing. During a period, they have a flat EEG. It's called postictal EEG suppression. So we think the EEG goes flat, they have decreased breathing, and then they have cardiac complications and die. There's a small number of patients who have autonomic disturbances with heart arrhythmias during the actual seizure. And they often have temporal lobe epilepsy, which activates like abnormal heart rhythms through the autonomic nervous system. And then they'll have asystole and die. That's rare, but it certainly occurs. The vast majority are in this postictal kind of mechanism group. Now here's a summary of recent literature on SUDEP risks. So uncontrolled seizures, particularly frequent tonic-clonic seizures, is the biggest risk for SUDEP. Most patients die unobserved sleeping alone. Nocturnal seizures, particularly nocturnal convulsive seizures, are common in SUDEP patients. They're often found in the morning, deceased. Many patients are found prone at the time of death, the majority. It's a little more common in males, but can occur in males or females. And so one message from this, the treatment plan should reduce tonic-clonic seizures to reduce the risk of SUDEP, and patients with nocturnal seizures can be encouraged to avoid sleeping unaccompanied by a caregiver, or maybe using a device that would wake up and alert a caregiver of a seizure. Now, so we've been tracking seizures and trying to get a feel for what happens during and after a seizure. And this is the data from our EpiWatch app. And what it shows on the bottom is those little spikes are movements. Okay, so what's happened is they had a focal seizure where you can see a few spikes, and then it flattens, and then it builds up into the tonic phase of the seizure, and then the clonic phase of the seizure, where you see those high voltage, high amplitude rhythmic movements. And this is a color plot of the rhythmicity of the movements during the seizure. And the heart rate is those little dots there. And you can see the heart rate elevates quite a bit and stays elevated following a tonic-clonic seizure, but not particularly early in the seizure. And here's a seizure. So here's the tonic phase of the seizure. And that's where we detect the seizure with the EpiWatch. Those little movements are very distinctive. Okay, so patients may have a focal or a generalized onset seizure, and then they evolve into the tonic and then the clonic phase. During the tonic phase, they get stiff. And during that, they vibrate. And we can detect that very specifically as a seizure. And then they go into the clonic phase, followed by the postictal phase. I'll show that in the next graph. So here's the focal onset seizure. You can see this rapid sort of vibratory movement. That's the tonic phase where people are stiff and shaking. And then to the right, you'll see it slow down and you form the clonic phase of the seizure. I'll show you that. That's the clonic jerking at the end of a tonic-clonic seizure. You can see these little clonic movements, but they're about to end. So now the clonic phase ends and he becomes just limp, and listen to his breathing. So what happened is he had a clonic phase of the seizure, it's tonic-clonic, and then at the end of the clonic phase, the EEG goes flat. And during that time, the whole body is limp and paralyzed, and the EEG is flat. During that time, the throat collapses and they get a snoring breathing pattern that's a kind of a partly obstructed breathing pattern called sturdor. And that's the snoring you heard. So we think there's probably risk right after a seizure where people are limp. And if they were face down sleeping at that time, they may be asphyxiated at this point. Here you've gone through this massive exertion. It's like running a 400-yard dash. Your body has lactic acidosis and cortisols elevations, and your O2 is down. You've got to do some breathing to recover from this big physical event. And right here, they're paralyzed. And some people, unfortunately, may not be able to compensate if they're face down or just not able to breathe normally at this stage. And so here's the post-ictal EEG period. And you can see the accelerometer data on the bottom. There's just flatness. So people are limp following a tonic-clonic seizure. And we think during that phase, they're at risk for SUDEP. And here's the time that people have to help a person with epilepsy. These are the average times for these phases of a seizure. So the ictal period, that's the tonic-clonic phase, averages 92 seconds. The post-ictal EEG flat period is about a minute. The sturdor, where they're breathing with this obstructed breathing pattern, is about a minute and a half. The post-ictal immobility was 200 milliseconds on average. And then the confusion lasted a long time, often 10, 20 minutes. So that's for the bilateral tonic-clonic seizure. If you have a complex partial seizure or focal unaware seizure, you just don't see this. And so the post-ictal EEG suppression, the sturdor, all that lasts about a minute to 2 minutes. And that's the time where you want to help the person during the seizure. And the actual seizure lasts about 90 seconds. So you have 90 seconds to detect the seizure, come help the person, and help them during that post-ictal period that lasts a minute or two. And we think this is what happens. It's basically like severe exertion to go through a tonic-clonic seizure, and they have to have respiratory recovery following the seizure. The O2 drops a bit during the seizure. Some people have a little apnea. They have a tendency towards it post-ictally, and they may be especially prone to developing SUDEP. And the respirations are slowed during the seizure. It's usually increased, but it's slightly obstructed after the seizure. So we think the best thing to do is turn them on their side and make sure that their ventilation is clear. And so this has been shown in a practice guideline from the American Academy of Neurology, where it's been shown that nocturnal supervision of people with convulsions may reduce risks of SUDEP. Sometimes you can use a listening device. Now you can use monitoring devices to detect seizures. But having tonic-clonic seizures and having them frequently, and then not adjusting treatment to stop them, and then not having nocturnal supervision, those are the risks for SUDEP. And so you want to reverse all that. Control tonic-clonic seizures, monitor the person at night, and prevent SUDEP. And so we think probably the sequence that should be followed is someone has a convulsion, detect the seizure, alert the caregiver, and in that post-ictal period where they're immobile and they're having this obstructed breathing pattern, turn them on their side and stimulate them. If they happen to have near SUDEP, you can resuscitate them with CPR. Most people, that's not needed if you're there and turn them and stimulate them and assist them with their breathing. And so our idea is to use seizure detection to get caregivers in to help people following convulsions, and that might reduce risks of SUDEP. We're doing a study now, though, where we're randomizing, where we're adding to this a basic life support approach, where you do a neck tilt chin lift maneuver. When we do that, that obstructed breathing pattern you heard in that patient goes away. So we think sometimes you can help open up the airway following a tonic-clonic seizure if you just tilt their head back. And so SUDEP is a very significant risk in people with uncontrolled tonic-clonic seizures. And it's a tragedy when this occurs for everyone. And we want to try to prevent this. And we think the clue is, or the key is probably to prevent these post-ictal respiratory events. And so we think turning them, giving them seizure first aid, but in particular, preventing tonic-clonic seizures with adjustment of medications is probably the first critical step. But if for patients who have persisting tonic-clonic seizures, it's very important to provide post-ictal care so they will not suffer SUDEP. Thanks very much for having me. Are there any questions from the moderator?
Sure. Thank you so much for doing this for us today. Fantastic information. I do have a few questions for you. So the first one, what kind of seizure first aid might help persons with tonic-clonic seizures?
Yeah, so what we would recommend is right at the end of the seizure, after they've stopped having their shaking clonic phase of behavior, turn them on their side. That's when they're limp. And just turn them on their side. That helps respirations. Stimulate them a little bit. Just make sure there's nothing in their face and just let them recover. We are doing a study, though, showing that potentially doing a neck tilt maneuver with chin lift could improve respiration, potentially open up the airway, because it does seem to prevent this obstructed breathing pattern. So basically, following any tonic-clonic seizure, turn them on their side, stimulate them a little bit, stay with them for a minute or two until they've recovered enough to breathe on their own.
Great, thank you. The next question is, you talked a little bit about detection devices. So how would a detection device assist someone who does not have nocturnal supervision?
Right, so the idea is to wear a device of some type. There's several watch devices, and these devices are very sensitive and accurate for detecting tonic-clonic seizures. They vary quite a bit in their false positive rate, where you get a lot of false positives in certain patients. Our device, we trained it on a playground, so we don't get very many false positives. Kids are drumming and shooting baskets and things. But basically, people could sleep with their watch device, and if they have a tonic-clonic seizure, it sends a message to the caregiver, and then the caregiver can come in and assist them.
Okay, so then a caregiver who does not live with the person would still be notified and then could come assist.
Right, but remember that window where tonic-clonic seizures last about 90 seconds, and the recovery period is 1 to 2 minutes. So you have to be there in that time frame. So the detections are pretty early, within 30 seconds usually of the onset of the convulsion. But it gives you a minute or two to show up and help them. So people who live alone are going to be at risk. But the key really is to treat tonic-clonic seizures. And it turns out with most of the newer drugs, if you look at their responses, most patients can have their tonic-clonic seizures controlled, even if they're having some focal unaware seizures. Often the tonic-clonic seizures can be controlled with newer treatments.
Okay.
So I wouldn't put up with tonic-clonic seizures. That's one message.
Right.
Yep.
Okay. And then the last question that I have for you, how are non-EEG seizure detectors, how do they identify convulsions versus other movements like exercise?
Right. So as you saw, I tried to show that a bit on that individual with our EpiWatch data. And on the accelerometer, you can see during the tonic phase of the seizure, people are very stiff and have this vibrating movement that is very distinctive. Almost nothing else is like that. So if we see that type of movement going on in a sustained way, we can very accurately detect tonic-clonic seizures. And then they go on and have the clonic jerking. And so these elements of movement can be detected very well with a watch device.
Okay. Can you tell us a little bit about how far in the future do you think the EpiWatch will be available?
Right. So we're doing a FDA clearance study now, and it should be available maybe towards the end of the year. It's available now with beta testing. For a while, we had it available through the App Store, but we've kind of pulled it back while we're completing an FDA clearance study. The Embrace Watch, which is similar, is available now through prescriptions.
Okay, that's great. So if a patient were interested in some type of detection device, either one of those, would they talk to their doctor about that, or how
Sure,
do?
they could get advice from their doctor. They can, look at this slide talk. There's some articles in the literature about these devices, but they can try them out and see if it works for them. But it's really, these are designed for people to screen for tonic-clonic seizures.
Okay,
At this point, it's not very good for detecting focal unaware seizures, though you can often kind of profile them with these kind of movement data captures on the watch.
okay. And are these devices, is a prescription required for them?
The Embrace Watch is prescriptions required. We will be putting probably a free version for testing as part of a research project and on the App Store, in a while, not too long. But eventually there'll be prescription devices that are FDA approved, and you can get a prescription to obtain them. And some insurance companies will cover that. Many of them do.
That's great. Well, Dr. Kraus, thank you so much for being with us today. We really appreciate your time, and this was just excellent information.
Yeah, sorry I couldn't be here live, but thanks for allowing me to present. Thank you.
Okay, thank you.
Okay, bye-bye.
Okay, so I'm going to go through a few of the questions. I'm not sure if I'm going to be able to answer them. If I'm not able to answer them, then I will send a message to Dr. Kraus and see if I can get them answered. So let's see. So yes, the recording will be made available. He did, as far as the Embrace Watch, I think he just briefly mentioned that. Oh, Megan, thank you so much. There's the link for that. I appreciate that. There's the link for it. Okay, and that was the only question that we had with that. So I appreciate your patience this morning with the volume, and we're going to get ready to start Dr. Margiotta and women in epilepsy. So hang on for just a moment. Dr. Margiotta, I just want to make sure you've got the ability to share your screen. So
Yeah.
I'm going to introduce you, and,
Sure.
and then we'll go ahead and let you take over.
Okay, let me make sure that's working okay.
So our next presenter is Dr. Megan Margiotta. She's the Associate Professor of Neurology at University of Maryland Medical Center. She completed her neurology training at Thomas Jefferson University Hospital. She then went on to complete an epilepsy and clinical neurophysiology fellowship at Jefferson. She joined the epilepsy faculty at the University of Maryland in 2020. She has a special interest in women's health and started a Women with Epilepsy program at the University of Maryland. This program is unique and one of the only specialized women with epilepsy programs in the region. The program focuses on specific issues related to women, including family planning, pregnancy, and bone health. So we're very happy to have you with us today.
Thank you. All right, let me see if I can get my screen shared correctly. Can you see my screen okay? Okay, and it looks just like the regular view.
Yes.
Okay. All right, well, we'll get started. We'll jump right in. So thank you for having me speak today. I'm going to be discussing women with epilepsy, and the title of my talk is What to Expect When They Are Expecting. So I have no conflicts of interest related to this topic. So my objectives for the talk today is I'm going to start by trying to clarify some common misconceptions about pregnancy for women with epilepsy. I'll provide some recommendations for what you should do before and during pregnancy, and then we'll review tips for after delivery. So I'm going to start with just some quick facts, some statistics to show you really there are so many women in the US that have epilepsy and also that are pregnant. So there are at least 1.1 million women in the US who have epilepsy that are childbearing age, and there's approximately 24,000 babies that are born to women with epilepsy each year. So in the presentation, I have a list of the most common questions from my patients regarding epilepsy and pregnancy. So I want you to decide for each statement if you think it's true or is it a myth. You can either put it in the chat or just kind of think to yourself. All right, so the first one that I have is, before I get pregnant, I don't need to do anything differently because of my epilepsy. Do you think that's true or a myth?
We have a lot of people saying myth.
Good. Let's see, I'm just having a little trouble advancing. There we go. You all were right. It is a myth. So you want to make sure that you talk to your doctor before you're pregnant because there are some things that we want to do. You want to confirm that you're on the safest medication for pregnancy. And then for some patients, we'll need to either adjust the medication that you're on or the dosing. And then in addition, your doctor will probably want to check a blood level to check for your anti-seizure medication blood level. And so that will be done before pregnancy. The second thing that you will want to do is start folic acid, which is a vitamin I'll talk about a little bit more in detail on the next slide. So you want to start that supplementation and your prenatal vitamin. So those are two things that we want to make sure that you do before you get pregnant. So what is folic acid? It is a B vitamin. And before becoming pregnant, we recommend that you take the prenatal vitamin and some extra folic acid. So in the prenatal vitamin, there is some folic acid, but most epilepsy doctors will recommend an additional supplement. And why do we recommend folic acid? It's for a couple of reasons. It lowers the risk of having a birth defect, which is really important. And in addition, there have been studies that show that folic acid is associated with a lower risk of having autism and also babies having an improved IQ. So it is important to take folic acid. And you want to take it before you become pregnant and then throughout the pregnancy. And the reason we recommend this is because the highest risk of birth defect is in the first trimester, which is the first couple months of pregnancy. So most women won't know that they're pregnant until 4 or 5 weeks into the pregnancy when they miss their period. And at that time, many of the major organs have already developed. So that's why it's important that you want to take folic acid before you plan to become pregnant. Okay, women with epilepsy have trouble getting pregnant. Do you feel this is a myth or this is true?
We have several myths,
Okay.
a true. The majority are myths.
Okay, you guys are right on it today. So yes, luckily it is a myth. So there actually used to be data that was supporting the idea that women did have trouble getting pregnant, but actually more recent data has shown that if you have epilepsy, you have the same likelihood of getting pregnant as someone who does not have epilepsy. So that's the good news. The next statement that I hear often from my patients is that they feel that they should stop their epilepsy medication before becoming pregnant. Do you think this is true or a myth?
We have myth.
Good, very good. Perfect. Yes. You don't want to stop your anti-seizure medication unless you're directed by your doctor to do that. And most neurologists will recommend that you continue the medication during pregnancy. Sometimes we will either change the dose or you might need to be on a new medication, but sometimes we'll leave you on exactly what you have been on or taking for a while. But that's why it's important to meet with your doctor before you get pregnant so you guys can discuss the different options and determine what the best medication is and what the best dose is for you before a pregnancy. What about this one? Getting pregnant is not safe because pregnancy will make most seizures worse.
Myth.
Good. You guys are getting them all. I do have some truths in there, I promise. So usually seizures actually don't worsen during pregnancy. And the majority of patients don't have any change in their seizure frequency or their seizure pattern. So to answer this question, there's actually some recent data that we have from the MONED trial. That was a study that looked at the risks and outcomes in pregnancy for women with epilepsy and for their children. So I will show you some of that data now. So I'm going to just walk you through this table. So let me come over here. So this column here shows pregnant women with epilepsy, and this is a control group. So this is women with epilepsy who are not pregnant. And it looks at the change in seizure frequency, and it's during the pregnancy for the pregnant women and for the same 9 months for the control patients who are not pregnant. And they found, you can see most people that are pregnant, no change in their seizure frequency. Some patients do have an increase in seizures during pregnancy, about 23%, but that's pretty similar to the general population who might just have an increase in seizure frequency over the same time period. So really no difference between these two groups. And again, the majority of patients who are pregnant will have no change in their seizure frequency. The other interesting thing that this trial found, which I think is important to mention, is that you're most likely to be seizure-free during pregnancy if you have not had seizures for at least 9 months before you get pregnant. So that's why it's really important to have good seizure control before you get pregnant. So what can cause an increased risk of seizures in pregnancy? There are a couple of things. The first is if you don't take your anti-seizure medication. Not going for blood work, because often we'll have to adjust your medication dosing during pregnancy. So if you miss getting blood work, the level could be too low and you might need a dose adjustment. And if it is too low, then sometimes you can have a seizure related to that. And the other thing is sleep deprivation can be a trigger seizure during pregnancy. So seizures during pregnancy can be harmful to the baby. Is this true or a myth?
True.
This is true. Exactly right. So if you fall, both you and the baby could potentially get hurt if you fall with your seizures. And the other kind of seizure is if you have shaking with your seizures, they're called tonic-clonic or grand mal seizures. So if you have convulsive seizures, sometimes the baby can have less oxygen during the seizure itself. But there are ways to reduce the risk of having seizures during pregnancy, and it's our job to help you to not have seizures during pregnancy. So how can I reduce the risk of having a seizure? There are a couple of things. First is to make sure you're taking your medication as directed. You don't want to stop it or change the dose on your own. Going for those blood tests that we talked about to check the blood level. You want to let your doctor know if you're starting any new medications, or if you're experiencing a lot of morning sickness. We say morning sickness, but often women can be pretty nauseous or have vomiting kind of throughout the day. And if that's preventing you from being able to take your medication, then it would be important to let your doctor know about that. And then again, trying to get enough sleep and rest if you can. So since I have epilepsy, my child will also have epilepsy. So I didn't do this as a myth or truth because the answer is more in between. It's not likely. So epilepsy can run in families. It can be genetic, but most epilepsies are not inherited, meaning it didn't come from your parents. So the risk of developing epilepsy in the general population is about 1%. And if you have epilepsy, the chance of your child having epilepsy ranges from 2 to 5%. So it's not likely that because you have epilepsy that your child will have epilepsy, and it's certainly not a definite. I need other testing during pregnancy ordered by my epilepsy doctor. So we're back to, is this true or a myth?
Well, people must be not sure because they're not answering this one. So why don't you tell us?
That's fine. So this is true. So most patients will need to get additional lab work or blood tests during pregnancy, typically about once per month to check the level. Your doctor may also check a level if you have a breakthrough seizure or if you're having some medication side effects. But due to metabolism changes in pregnancy, the amount of medication may be lower in the body. So most women actually will need a higher medication dose. Usually your doctor is going to target the same blood level. So even though the dose of the medicine is going up or increasing, the amount of medication in the body will stay the same. So your baby won't be exposed to more of the medication. I know that can be a concern for some women. If the level is too low, that can increase your risk of having a seizure or a breakthrough seizure. The other additional testing that you need, which may be different than someone who doesn't have epilepsy, is a more detailed anatomy ultrasound called a level 2 ultrasound that your OB will order. So this is just a graph, again, from the Monid study showing pregnant women who have epilepsy versus women who have epilepsy who are not pregnant, looking at the number of women who needed to have a change in their seizure medication dosing. So pregnant women who have epilepsy are more likely to need a change in the dose of their medication. And often that dose has to be increased during pregnancy. So 74% of women needed a dose increase or a change. All right, the next one, myth or true, I need to have a C-section delivery, which is the surgery to deliver the baby. Is that a myth or that's true?
We have myth.
Good, perfect. Yeah, that's exactly right. So you can have a normal vaginal delivery. A C-section is not an absolute just because you have epilepsy. Sometimes patients who have epilepsy will need a C-section for another reason, but having epilepsy alone is not a reason to have a C-section. So most babies are born healthy. Is this true or a myth?
True.
Good, perfect. That's the good news, yes. So the incidence of a birth defect in children of women with epilepsy is 4 to 6%, and the general population, the incidence of birth defects are 2 to 3% for the general population. So there is a slightly higher risk for having a baby with a birth defect compared to the general population. But this number is even lower if you're on the safest medications that we most frequently use in pregnancy. And actually that risk is almost the same as the general population if you're on the safest medications. But if you look overall, it means that really 94% of babies are healthy and normal. And the increased risk overall is small, but we do want to reduce that risk as much as possible. There are some ways that we do this. One is to choose the safest medication in pregnancy. We also try to choose the least number of medications and the lowest dose to control your seizures, or the lowest effective dose. And that's why it is important, again, just to see your doctor before you're pregnant, so that way they could make medication changes if they need to. So this is a graph I wanted to show you from Paige Pennell. She is a leader in women with epilepsy, gives a lot of national talks, and is now in a hospital in Pittsburgh practicing, but she publishes a lot of the data that we use for women with epilepsy. And this is a graph just kind of showing the risk of a birth defect. And this is kind of the increasing the most risk, and these are the medications with the least risk. So some of you may be on a medication called lamotrigine or Lamictal, or levetiracetam or Keppra. These are the two safest medications that we have in pregnancy. These three medications here are also relatively safe, and valproic acid is the one that we know has the highest risks of birth defects. So typically we don't have women who are pregnant on this medication. There are some circumstances where they need to be on it, but for the most part, we try to avoid this medication if we can for women that are going to be pregnant or could get pregnant. So this is a busy slide, but I will walk you through this one. So this is data from pregnancy registry. So a pregnancy registry looks at different medications that a mom might take during pregnancy and how that affects the baby. So there's three different registries. There's one in Europe, there's a North American one, which is the one that we use in the US, and then there's a UK and Ireland pregnancy registry. These are 8 different seizure medications down here. And you guys might be familiar with some of them if you're taking them, or you know someone that is on these medications. But on this graph here is looking at the risk of a birth defect. So all the pregnancy registry data actually had pretty similar results across the 3 different registries, that the safest medications here are levetiracetam or Keppra, lamotrigine or Lamictal, and oxcarbazepine or Trileptal. And the highest risk of a birth defect for the 3 pregnancy registries was with valproate or valproic acid. So for patients with epilepsy who are planning to become pregnant, we have to balance the potential risk of a birth defect, which is overall low risk, with the risk of having uncontrolled seizures. So we have to balance these 2 things, which is why I like to show this picture. But from the beginning, it's important that you have a discussion with your doctor to kind of address any of your concerns and to make those adjustments before you get pregnant. Okay, the next one, I should not breastfeed.
Myth.
Wow, you guys, I mean, that's exactly right. So it's interesting because actually, not only do my patients think that they shouldn't breastfeed, but there are many doctors, nurses, other healthcare professionals who also are misinformed and think that their patients that are on anti-seizure medications cannot breastfeed, but it's not true. That we've had a lot of data come out from the Monid trial supporting breastfeeding. So we do encourage it if the patient is interested in breastfeeding. Being on a medication is not contraindication to breastfeeding. We generally consider it to be safe. And the amount of medication that's in breast milk is actually less than the amount of medication during pregnancy that the baby was seeing. And remember that babies have already been or seen on the medication for the 9 months that you were pregnant. So one of the ways we can reduce the amount of medication that's in the breast milk is if you take the medication after a feeding, that can be helpful. And studies have actually found that the IQ of children who are breastfed was actually slightly higher than babies who are not breastfed for women with epilepsy. So just to touch on some newborn safety and postpartum tips. So I do recommend avoiding using a changing table and instead changing the baby's diaper on the floor. In case you have a seizure, it would be safer for the baby to be on the ground instead of elevated off the ground on a changing table where they're not being monitored. You should have someone with you when you bathe the baby, so not bathing the baby alone. If you have a seizure, then the baby could potentially be in water by themselves, and there's a risk of drowning. The other thing to try to do as much as you can is to get enough sleep. I know this is a tough one for new moms, but I try to encourage moms to have one longer stretch of sleep overnight. So generally, I recommend 6 or 7 hours of uninterrupted sleep where family or friends can give 1 or 2 of the bottles. When I say 6 or 7, I'm really hoping maybe you'll get 5 or 6 hours of sleep, but you do the best you can because sleep deprivation can certainly be a trigger for seizures in a lot of patients. Another thing that I recommend is discussing birth control options with your OB-GYN after you deliver. Some birth control could be made less effective because of your anti-seizure medication. It interacts and makes the birth control less effective. So it's important to talk with your OB-GYN about which birth control option might be best for you. And the last thing I want to make sure is that we are monitoring for postpartum depression. The incidence of depression is overall higher for patients who have epilepsy. So it is important that you talk with your healthcare team if you're feeling sad or depressed. It's something that we definitely want to monitor and address if that comes up. So just to go through a summary of kind of what we talked about. From this talk, you can see how important it is to have a planned pregnancy and to discuss pregnancy with your doctors before you try to become pregnant. You want to take folic acid and a prenatal vitamin to lower the risk of birth defects. They should be started before pregnancy and then continued throughout the pregnancy. Remember, most women will not have an increase in seizures during pregnancy. You want to get your seizure medication levels checked. They do need to be monitored more frequently during pregnancy so that your doctor can increase the dose if it's needed. Don't stop or adjust your medications unless directed by your doctor. We do encourage breastfeeding if that's something that you're interested in doing. And really importantly, remember, most women with epilepsy will have a normal pregnancy and a healthy baby. So I just wanted to conclude by letting you know about our Women with Epilepsy program at University of Maryland, as we mentioned in the beginning. The program officially launched in September of 2021, and we're one of the only centers in the region to have a Women with Epilepsy program. We know that there are specific issues that in particular women with epilepsy face. So in this program, we're focusing on a variety of women's health issues, family planning and contraception, talking to patients if they have seizures related to the menstrual cycle, which is called catamenial epilepsy, caring for women during pregnancy, and then also having discussions about hormone replacement and bone health. So what can you expect at a visit? So for our pregnant patients or those planning to become pregnant, we have a rapid referral track with the goal of seeing patients within about 7 to 10 days of the referral. We know that medication levels can change even really early on in the pregnancy. So we try to see these patients quickly in the office. At the visit, we'll discuss medication options and dosing, what lab work you need, and then counseling on some of the topics that we actually talked about today, folic acid supplementation, newborn care, and breastfeeding. This is just a screenshot of our website if you need to get more information or are interested in learning a little bit more. And then I just also wanted to mention the North American Anti-Epileptic Drug Pregnancy Registry. So this registry again looks at the effect of anti-seizure medications during pregnancy on babies. It is just a phone interview. There's no like extra blood draws or extra testing that's done. And this actually will help us determine over time which of our medications are safe during pregnancy and which aren't. So it can be very helpful for current and future patients if you're interested in registering. And I think that's it. I think I left some time for questions if anybody has them.
So any questions you can type into the chat box.
We'll give everybody a minute. Think about it. I'm glad everybody played along. Yeah, and you guys, you got them all, right too, which is awesome.
We got to thank you so much for the presentation. Very informative. Thank you for the presentation. Some of these topics I hadn't even considered yet for my daughter. Can you see the chat, Megan?
Yeah, are all seizure medications, let's see, equally safe for breastfeeding? So we feel that, the medications in general are safe for breastfeeding. There are some that are newer, we don't have, a lot of data about, but the general consensus is that the medication that you are on during pregnancy, the baby kind of has already been exposed to that medication. So then when you're breastfeeding, the dose is actually much lower. So we try to get patients on the safest medications during pregnancy, and then usually you're going to stay on the same medication. I don't know that we have specific data for each individual seizure medication for breastfeeding, but the general consensus is that the medications used that are used for anti-seizure medications are safe for breastfeeding, and that the medication that you were on, we are going to choose the safest one for pregnancy. That's going to be the medication that you're still on when you're breastfeeding, and the baby's already been exposed to that medication.
Okay.
Well, thank you, everybody.
Thank you so much for joining us today. And is it okay to share slides if anyone is interested?
Sure, absolutely.
Okay.
All right, thanks, everybody.
Have a great day. Thank you so much for joining us this morning. Okay. So next up is our epilepsy success stories. So it's just going to be a few minutes. We're starting a few minutes early. So actually, if anyone is interested in taking just a quick 5-minute break while we get the success stories all set up, you're welcome to do that. But please be back by 10:15. We're going to start promptly at 10:15. Okay, everyone, we're going to get started again. And our next session is talking about some epilepsy success stories. So I'm really pleased to introduce two of our speakers today. The first one is Claudia Barrett, and she is a patient. There we go, I'll show you the pictures of our two speakers. So Claudia is 58 years old. She's a computer professional, having worked at IBM for just short of 25 years as a software engineer. She landed early on in customer support, where she derived much satisfaction from solving complex software issues for all sorts of well-known companies in the US and around the world. In her spare time, she loves playing guitar, singing with friends around a campfire or piano. She also enjoys gardening, ultimate frisbee, and photography. She enjoys visiting her parents out in the country, getting away from it all, hiking trails on their land, working the tractor with her dad, hitting flea markets with her mom, and countless other fun activities with family. She's had partial complex epilepsy since early puberty, around 13 years old, and thankfully in later years, finally landed on prescription meds, which effectively eliminated her seizures. It's been a learning process all these years in terms of finding out what works and what doesn't. But she thanks God for the various revelations and meds that happened upon her during her journey with epilepsy, and as a result, has been able to experience a full and blessed life. So Claudia, if you can just tell us a little bit about your journey with epilepsy.
You're on mute.
Claudia.
There we go.
There you go. Thank you.
I know I do this all the time, and you'd think
That's
I'd know
okay.
turn the mute off. Thank you.
I do
Yeah.
too.
Anyway, yeah, so what I did was I wrote out a little outline to kind of keep me on track here of the 3 stages of my dealings with epilepsy. And the first being when I first started having seizures, which happened around puberty. The second part was when we finally discovered that epilepsy was what I was experiencing, and getting on medication for the first time, and that was Tegretol. And then my third phase was when I finally discovered time-release Tegretol or carbamazepine and the difference that made in my life. So in terms of when I first started having seizures, of course, we didn't know what they were. We used to call them headaches, and I would just kind of black out and not necessarily fall over. I didn't lose complete consciousness, but I can remember many times when I would feel this way, like in junior high and such, when they first came on, I would just go to the nurse's room and pretty much just sleep the whole day in the nurse's room. I would just be wiped out for the whole day. And then having kind of seizures throughout the day. I remember that after I would come out of the seizures, that I couldn't talk. It was like it would zap my language area of my brain, and that was always bizarre. But and the other thing that I noticed early on, those I tried not to listen to music or the radio when I knew I was having a seizure day, because it seemed like somehow music would also sort of trigger my seizures. And then anyway, eventually, through the help of my aunt, who was a nurse, we ended up at a neurologist, and the EEGs finally showed that I indeed had epilepsy. I went on Tegretol, and for the most part, my seizures were fairly well controlled. I was able to get a driver's license and all of that sort of thing. But I found as I went into college and into my 20s that I was still having issues with breakthrough seizures. And I already knew that I had to be careful about trying to remember to take the medicine every day, the same day, that sort of thing, because a dip in the level of the medication could be enough to cause a seizure. But it seemed like even when I was absolutely diligent and religious about taking all of my medication, there were still times when I would still end up having seizures just out of the blue. Now, I eventually just sort of started to put 2 and 2 together and started to notice that many times this would happen when I would get my period. And I mentioned that at one point, during one of the doctor visits, and they said, yeah, sometimes they had heard reports from women saying that they had experienced similar things. The other main thing that happened when I was on Tegretol was I ended up, originally I wasn't in customer support, but when I did end up in customer support, I had to carry a pager every 3 weeks. And this was another major thing that I discovered over time, was that I was getting pretty much woken up in the middle of the night to handle these urgent customer calls. And I started to find that it was almost like every 10 days I just was having seizures, and there was nothing that I was doing in terms of missing medication or anything. It just out of the blue, so I thought out of the blue, I just started having seizures. And again, I ended up back at the doctor trying to discuss what was going on, and that's when I learned that interrupted sleep was something that could also trigger seizures. So fortunately, I worked with my boss, and we decided that I couldn't actually take those calls in the middle of the night anymore. So then fast forward, I was down in Texas during that time of my life. And then I moved back to Raleigh, or not back to, rather back to the East Coast. And I ended up in Raleigh, still working for IBM. And that was when I got a new doctor And then that was when my whole life changed in terms of my seizures, because originally I figured, okay, she'll just write me another prescription for Tegretol, which was what I was already taking. And she said, well, let's try this other thing. Carbitrol was I think the brand name at the time. And she said, it's basically time release medicine, and it just seems to work better. So, okay, I went ahead and did that. And the difference was just amazing. For almost the whole time that I've been on the carbamazepine, it almost 100% prevented my seizures. The only bizarre time was when I was playing this highly competitive ultimate frisbee and doing lots of track workouts and things like that during the week. And that when I first joined this team and was under all this, my body was under duress from all of this athletic workouts and everything, I actually stopped having periods for a couple of months. And during that time as well, I had a couple of breakthrough seizures here and there. But once I stopped playing at that level, it was only after a couple of months. I was still playing hard, but my periods came back and the seizures stopped happening. And pretty much, I mean, it's been, that was the early 2000s. And I have pretty much been seizure free using this time release medicine for going on almost 20 years now. And it's been truly a remarkable medicine for me. So that's pretty much my story in terms of the beginning to the end to the current place where I am now.
Thank you so much for sharing that with us. We're going to hold questions until we hear the other story.
Okay.
So if anybody has questions for Claudia, feel free to type them in the chat. But we are going to go on to introduce Shannon Aguilar, and she's joining us by phone today. And Shannon is actually a caregiver, and she has 2 children, a son and a daughter, who both have VNS therapy. She lives in Orlando, Florida. And like I said, she's joining us by phone, and I'm so happy that she was able to join us and tell us a little bit about her story of being a caregiver.
Hi, good morning. Thank you guys for inviting me to share the story of my children. First, I wanted to talk about my daughter Isabella, because she's now 15, but she was diagnosed with epilepsy at 18 months old. She was actually diagnosed by accident. We were in the hospital for she had pneumonia, and the doctor said, hey, she's having seizures. And we're like, what? No, I know what a seizure looks like. She's just a space cadet. She tends to stare off. It's not a big thing. And he says, no, I really think you need to get in with a neurologist. And I think you need to get in one right away. So we were discharged on a Saturday, and we were lucky enough to get into one of our, who's still our current local neurologist, on Monday. And she was hooked up, had the EEG done. And before we even left, she said, she's having, a ridiculous amount of seizures. I think it was close to 80 seizures a day is what we ended up finding out. And we were like, oh my word. And we were told, what to expect for quality of life going forward. And of course, she was 18 months old. So she was really young. At that point, we hadn't seen a lot of missed milestones, but they said as she got older, it would change. And obviously, once she hit puberty, it could change even more. So her journey is a very interesting one, because it took us until she was in 5th grade before we found out about a treatment that would work for her. Throughout that time, she would have pretty large seizures that would make her miss days of school. She would have memory loss, where if she had a seizure on one day, there would be several days of recovery just because of her little body was so exhausted. We as parents pretty much turned our lives upside down trying to figure out a treatment or something that would work with her. At that point, I think we had been to 3 different children's hospitals, and all of them kept saying, she's so unique. The case is unique. She had been on, I think, 10 different medications, cocktails of up to 6 at one time, just trying to find a dose or a cocktail or even one that would work. And none of them were working. Along the way, we ended up finding out about VNS therapy probably about a year before she was implanted. And during that time, we were still in the process of visiting another children's hospital for the possibility of different types of surgery. I was a little bit hesitant about VNS therapy just because at this point, we had been going through this for over 3.5 years, or for, oh my goodness, she was 11. So we had been going for close to 11 years. We had been going through this where we were trying to figure out what worked. Every treatment, every medication, as a parent and a caregiver, you get your hopes up that this is going to be the one. And it was scary with the possibility of VNS therapy because I didn't want to have that hope again that something could work. Where our story takes a major twist is right when we found out that Bella is actually having seizures that are discharging from both sides of her brain, that none of the surgeries would work. And we were talking about moving forward with VNS therapy. Well, let me caveat this by saying Bella was the first one on board. She did the research. She said, "Mommy, we need to do this." And my husband was like, absolutely. If she's this excited about it and she thinks that this could work, and I'm thinking to myself, here we go again. But right around that time, our son, who was going into first grade, started having seizures. And I think we had seen it maybe a couple weeks before the teacher pointed it out to us. We were seeing signs, but I think there was a big denial on my part because I'm like, no. Both of our kids aren't going to have this journey. We're going to have one that isn't going to have to go through what Bella has been through. So around that time, we had started getting him on meds and started figuring out what would work for him. At the same time, Bella ended up getting implanted with VNS therapy. Now, what I want to make clear is that for us, VNS therapy has worked. It's a treatment just like any other medication. And I think, it's something that is definitely a conversation that you should have. But before VNS therapy, Bella was actually failing 5th grade. I used to tell my husband, it's like literally watching a beautiful mind breaking again and again and again, and seeing her lose stuff and seeing her not be able to experience things that a normal elementary school child gets to experience. Sorry. She didn't go to sleepovers. She really didn't have a ton of friends. Her life evolved around doctor's appointments, medication schedules, hospitalizations, EEGs, anything that a child shouldn't have to go through. She got VNS therapy in spring break of 5th grade. Over the next 3 months, we slowly started to see improvement in her and her seizures and her mood, everything. It was interesting. By the time she started 6th grade, it was literally a completely different child in terms of her seizure control, as well as just what she could retain in school. Over the next year of school, she actually improved so much that in our county, in Orange County, which is our school area, she was actually the top 5% for math skills. So much so that as a 7th grader, she took the SATs. And I was sitting here, of course, in shock and going, but I know where she was in 5th grade. I know what her elementary school life looked like. And then if we fast forward to where she is now, she is going into 11th grade. She actually is learning to drive. It was something we never thought would be a possibility for her. But with VNS therapy, her seizures are so controlled. She's still having them, but they're only in the evening, or in the night, I should say, while she's sleeping. And all of her doctors have cleared her as long as she doesn't drive while she's sleeping, which we think is something we can definitely make sure doesn't happen. But she's going into 11th grade. She's looking at colleges. She's talking about going away, which is not something I'm happy about, but something that was never a possibility for her. We're looking at, as an 11th grader, she's taking all honors classes. She's starting college classes. She is taking extra classes so she could be prepared for the world. There's things that I'm seeing her do that when she got that diagnosis at 18 months old, we didn't think was a possibility. And it's amazing as a parent and as a caregiver to see her move forward in that. Now we're going to step back to with my son. When he was diagnosed, I remember, unfortunately, I didn't get the call. My husband got the call. And I was a complete mess at my office when my husband called and he said, hey, listen, the doctor just called. Ethan does have epilepsy. They've already called in a script. They need him to start it right away. The EEG was really bad. And I lost it. I thought, oh my gosh, here we go again. Well, ultimately, Ethan's journey was a little bit different because one, in our experience, VNS therapy did work. It wasn't something I jumped to right away. I thought, okay, we're going to give him the opportunity to find some medications that could work for him. Again, he's only had VNS therapy for the past 18 months. Bella's had it for 5 years. However, going over, the time of his diagnosis to 18 months ago, the medications that we tried for him, not only they didn't work, they completely changed his personality. We had a ridiculously lovable, happy, joyful little boy that turned out to be this little boy that he had anger issues, and he's my dad's best friend. Like, him and my dad are like little partners in crime. And my parents got to the point, they're like, Shannon, this is breaking our heart. We can't keep having him over for him to scream and cry about wanting to go home. And it was horrible because I think, as a family unit, it was tearing us apart in terms of we couldn't figure out what worked. Finally, after visits to 2 different children's hospitals, they had said, hey, have you guys heard of VNS therapy? And I'm like, well, interesting enough, my daughter, I consider her a success story with it. And I think, they said, well, we think that this is the next step for Ethan. Without hesitation, mid-pandemic, we were like, absolutely. So much so that we actually were able to, bypass all the red tape and get in for surgery. Looking at him now and where he was, he's back to the carefree, fun-loving little boy. He actually just spent the week at my parents' house, going to get pedicures and getting spoiled, and back to being my dad's little partner in crime and shadow. And honestly, as a parent, it's amazing when your child is succeeding, especially when you know what the results were supposed to be. The other thing I want to point out, which it was something I just realized over the last couple of years, probably the last 12 months, was one of the things as a caregiver that we were struggling with is my husband and I we weren't able to have the relationship that we needed. We were so focused on our children and making sure they were taken care of that somewhere along the way, we had focused our life on them and also not on us as a couple. Well, over the past 12 months, I have been able to go on dates with my husband. I have literally fallen in love with this man again, and we've been married 20 years. But for us, it was almost a new beginning. So not only did our children have these amazing results, but as a family unit, I feel we're stronger, we're moving forward. And for us, honestly, we are beyond blessed that they are as controlled as they are right now. So that's kind of our story as a family, as a caregiver, and as a parent.
Amazing stories. Thank you both, Claudia and Shannon, so much. I mean, I feel like both of you, the journeys that you went through really brought you, through the other side to be able to live a life that's full and one that you really enjoy. And I think that gives hope to so many other people who are struggling. So first, I wanted to ask a couple of questions, and then we'll go to the chat box and see what other questions other participants have to ask you. So I'm going to ask you both the same questions. So what's one thing you learned during this journey that you wish you would have known from the beginning? And I don't know who wants to take that first. Okay.
I think one thing as a caregiver, I will say, you're also taking, for a good 11 years,
Hey, Shannon, we're having a little trouble hearing you. Want to try again?
okay. Can you guys hear me better now?
Yeah, that's better. Thank you.
Okay. All right. I think as a caregiver, one of the main things that we learned is that while you're taking care of your loved one, you need to make sure you're also taking care of yourself. I think along the way, we let ourselves get run down more than we should have. And we could have tagged out, we could have, but for whatever reason, as parents, we definitely both wanted to be there for the kids. And I think, as a caregiver and a parent, I think the one thing I wish I would have known is to make sure I take time to breathe and take time to kind of recoup, because we are also going through what our children are going through.
Thank you. Claudia, what would you say about something that you learned during this journey you wish that you would have known from the beginning?
Yeah, I think in my case, it wasn't even necessarily that I was searching for something new. While I was on the Tegretol, I just thought, well, this is the best it gets. This is the best kind of success I'm going to have in terms of just dealing with breakthrough seizures every now and then, no matter what I do. I guess based on the fact that I found something that worked far greater is if you've got something and it's just still not quite right, to just still don't lose hope that there's maybe still a better solution, a better medication or something like that, or even some kind of change to your lifestyle. In my case, discovering the whole thing about interrupted sleep and how that can, be a trigger and that sort of thing. So I guess it's just to just don't settle if it's still not, 100% for you. And I realize it can't be necessarily 100% for everybody, but in my case, that change in medication was the difference for me.
Mm-hmm. So that kind of segues into another question that I had. Maybe you can elaborate a little bit, but if you were able to give one piece of advice to someone who was struggling to control their seizures, what would it be?
Yeah, I guess along with my story is just to be, I was so ignorant of the facts. I mean, it wasn't until things just started, failing, in terms of the sleep, in terms of all of that heavy duty exercise that I was doing and learning about periods is just continue to ask questions, continue to research what you can and do what you can on your own. I mean, not that obviously the doctors have so much information, but ultimately, yourself the best, and your symptoms, your schedule, all the different little triggers or whatever. And I think in that respect, you're more able than just going into the doctor's office and trying to remember everything, and just to trust yourself in terms of knowing what seem to be triggers and that sort of thing, and just researching on it.
Mm-hmm. Yeah, I think that's great advice. And one of the reasons that we wanted to do this today was to be able to, share some inspiration, some hope, some advice for other people who are going through similar situations. So I think that really is very good advice. Shannon, what about you? If you could give one piece of advice to someone who's struggling to control their seizures, or from the caregiver perspective, what kind of advice would you give to another parent who is struggling?
You know your loved one best. Whether it is a spouse or a parent or child, whoever it is, you know them best. You know what seems to work and what doesn't work. So I would say definitely speak up. That was the one thing I think we didn't do.
Oh, having a Oh, Shannon, we're having a little trouble hearing you again. Okay.
Claudia said, is to speak up. You know your loved ones, you know what they're going through.
Yeah. Shannon, we lost some of that. Tell us again what your advice would be.
Oh, sorry.
That's
I
okay.
said, I was kind of piggybacking off of Claudia in terms of, you know your loved ones, you know what's working, you know what's not. Definitely ask questions. Don't be afraid to ask about other treatments.
That's great. Thank you. Let's see what we have in the chat box here. Amazing stories. Let's see. Thank you for sharing, Claudia, especially interesting about the sleep interruption and hormone effects. Glad you're doing so well. Thank you so much for sharing. I'm happy you're doing well. That's awesome. And we have another response. I'm living this story. My daughter is 12 and has failed so many medications, non-typical absence seizures. We're still looking for something that works. Here's a question for Shannon. Shannon, how did it make you feel with being a caregiver to 2 children with epilepsy? I can't imagine having both children with epilepsy, knowing the challenges of epilepsy.
That is a very hard question. I think I have gone through every emotion that's out there. I think on the days that they're having bad days, I quietly break down because I can't do that in front of them. I feel like, they're having enough. They don't need to see, mommy upset. And they know. I think, the biggest thing is honestly, for me as a parent was always trying to improve their quality of life. I refused to stop until I found something that would improve that quality of life. So for me, it's been a really, really hard journey, but it's been one that I would do again and again for them.
Thank you. Okay, we have another question for Claudia. Well, actually, congratulations to both of you and your families. For Claudia, it's extremely rare to have musicogenic seizure triggers. My daughter has them, and you're the only other person I've ever met with them. Do you still have to avoid certain types of music, even on Tegretol ER?
Okay. Am I off mute? I just want to make sure. Yeah. So, no, that's the beauty of this extended release medicine for me, is that not only do I listen to music all the time. I like I said, I play guitar. I've been in bands. I've done it all. I mean, garage bands, but I've not had any issues with any kind of music triggers anymore. And the same thing with the interrupted sleep. I mean, for a while there, I was telling my managers I couldn't take any more calls in the middle of the night. And eventually it doesn't matter now. There have been numerous times where I'm taking calls in the middle of the night, or times where I'm getting 2 hours, 3 hours sleep or something like that, because work is just absolutely crazy. And it doesn't matter whether I'm sleep deprived. It doesn't matter whether I'm interrupted sleep. Certainly when I went through menopause and hot flashes were killing my sleep cycle, I didn't have any issues then either. So this medication has just been golden for me, both in terms of the music and in terms of the sleep cycles.
That's great. Another one for Shannon. Are your children on medication in addition to VNS?
So yes, both of my kids are on medication as well as VNS therapy. I will say over the years, our healthcare provider has made it a point to adjust the settings of the VNS therapy instead of adding medications. And I am very happy to say my daughter started off on 4 medications with VNS therapy 5 years ago. And this morning, she actually just decreased another one. So we're actually down to 1 medication. Again, this is their story. It's unique to them. My son is still on 2 medications. But yes, VNS therapy for them anyways is an addition to medication.
Great. We also have for Claudia, maybe menopause also helped Claudia given hormone issues in the past. Thank you again for sharing. And then we have another, thank you so much for sharing your amazing stories. And I have to agree, both of you, was really so wonderful to hear what positive outcomes that you've had, despite the challenges that you faced. And it's wonderful to see you both being able to live such a nice life, full and robust life. And Shannon, for you and your family and your children as well. Does anybody have any other questions or comments before we go to the next? Okay. Thank you both again for sharing your stories with us. Everyone, we are going to go on to break from here. So we're going to have a little bit more than 15 minutes. So if you can be back before 11:15, we'll start promptly at 11:15. And we hope for you to come back and see what we have in store for you next, because the next one is about wellness, and we're going to learn some very interesting techniques and tools to help with our wellness. So thanks again, and we'll see you at 11:15. Hello, everyone. Thanks for staying with us during the break, a little bit longer than we expected. I hope maybe you got some water or another cup of coffee and you're all ready to go for our next session, which is going to be really exciting and interesting and interactive. So I'm very happy to introduce Kim Foster. And Kim is a MSW, LICSW. So she has her master's degree in social work from Boston College. She's a licensed independent clinical social worker in Washington, D.C., and a licensed clinical social worker in Virginia. Her work experience ranges from child welfare to victim services to hospital social work. In fact, Kim used to work on the inpatient hospital side at MedStar Georgetown University Hospital before joining the MS and neuroimmunology clinic in August of 2020. So she joins us today to talk a little bit about wellness and mental health. So thank you, Kim, so much for joining us.
Great. Thank you so much for having me. Can people hear me? Yes, maybe. All right. Well, if you can hear me, that's great. We'll start with that. I'm just going to work to share my screen. Let's see. So it says who can share. It says host only. Let's see if I can do this here. All right. Can someone tell me if they can see my slides?
I can.
Okay, great. Somebody named Kara or Kara also shook her head. Thank you so much. All right. So we're going to do this. Great. I'm going to kind of shift this maybe off to the side a little bit. All right. So again, my name is Kim. Thank you so much for having me today and sticking with it after the break. I appreciate that. I work at Georgetown and I'm just so pleased to have been invited today. So why don't we jump in? I am a wellness champion at Georgetown Neurology. And that's throughout the MedStar system, including Georgetown. And it's just someone that has signed on to share wellness information, mental health information, checking in on team members. So I do that for the Georgetown Neurology Department. And so I randomly send out different things. And sometimes team members send things back to me that I share with other people. And one of the things that was shared with me from one of my providers is this quote, and if you do not make time for your wellness, you will be forced to make time for your illness. And I really find that that is what can happen, right? If we want to be our healthiest selves, we have to take time for that. And we have to take time to take care of ourselves. So not only do I talk to patients at Georgetown about taking care of themselves and what's happening in their lives, I take time to check in on my providers. How are you doing? How is your mental health? What is your stress level? When are you taking that vacation? Have you eaten today? Have you gone to the bathroom? All of those things. Do you need some water? What's life like for you? When was the last time you got some sunshine? And I also do that annoyingly, probably with friends and family. So I try to incorporate a lot of what I'm going to talk about into my own life and encourage others, whether it's in the professional world or my friends and family, to be doing a lot of the things that we talk about here. And this presentation is not just for persons living with a chronic disease or taking care of someone that has a chronic disease. I really see this as something that all of us, any of us, can use and maybe incorporate some of the things into our daily lives. So I would like to start with an exercise to set the tone for our time together. And that exercise is going to be deep breathing. There is a Buddhist monk, Thich Nhat Hanh, if anybody's heard of him. He actually died this year, but he's very famous. He's written a ton of books. And one of his quotes I really love is, breathe in deeply to bring your mind home to your body. And that is part of deep breathing. If anybody's ever told you to just breathe, right? If anyone's told you, listen, let's just breathe together. If you have any level of anxiety, you've probably heard of deep breathing exercises. I also do a meditation at Georgetown, and we're going to do a meditation later today. So I thought that we would talk about this breathing just for a minute and then engage in some deep breathing, probably for just another minute, just to have that practice. And then we can talk more about why deep breathing and mindful breathing can be good for your brain and your body. So in order to kind of be prepared for this, I'd love for you, wherever you're sitting, to kind of sit up straight as you can. And also say, you don't have to do this. You're all probably off camera anyways. If you don't want to do it, if you feel silly doing it, you don't have to. I hope that you'll continue to listen. But I don't ever want to push anybody into doing something they feel uncomfortable with. But it's just breathing, I promise. It's pretty easy. So if you can sit up straight, take one hand and put it on your belly. Kind of have your fingers out. Put that right on your belly. Because what we're going to do is, with our deep breathing, we want to be able to feel that hand on your belly expand. And then when you breathe out, you should feel that hand fall back down, right? So out, breathe in, then breathe out. So just hand on your belly will tell you if you're actually doing it. Because some of us, or most of us during the day, we're breathing from our chest. It's pretty shallow. But when we take a big yawn or we take a big breath, like, ooh, we feel that belly move. And that's what we want with this deep breathing. It's called diaphragmatic breathing. We don't have to go into that. It's just breath into the diaphragm. Okay. So I encourage you to close your eyes. And we do that to shut out visual stimuli. It's another way to kind of turn part of our senses off for our brain, to give it a little bit of space to rest. You don't have to close your eyes if you don't want to. Okay. Now, when we do our breathing, it's just long, slow, deep breaths in, preferably through your nose if you can do it. If you can't, that's okay. Through your mouth is perfectly fine. So long, slow breaths in, and those long, slow breaths out, like you're pushing all the air into a balloon, right? You've got to push all of that air out of your body, all right? So sitting tall, hand on belly, eyes closed if it's comfortable to you and you're in a safe space. We're going to start breathing long, slow breaths in and slow breaths out. I'll continue to talk through this, but you breathe at your own pace. Okay, so we're just going to do a few rounds of that together. So long, slow breath in. Push all that air out. Feel that hand go down on your belly. Long, slow breath in. Slow breath out. At your own pace. Slow breath in. Slow breath out. Just do a couple more. Long, slow breath in. And long breath out. One more. Slow breath in. Slow breath out. Very good. I invite you to open your eyes if you had them closed. Come back into the session. And so that was just a minute of slow breathing. And why do we do that? Why do people tell us to breathe? Why do people try to, when they breathe with us, to bring our breath down, to slow our breath? So belly breathing stimulates the vagus nerve, which runs from our head down in our neck, through our chest, down to the colon. And this activates a relaxation response. It can reduce your heart rate, it can bring your stress levels down, it can regulate your breathing, it can also calm your amygdala, this little tiny peanut that's in your brain that isn't responsible for your fight or flight or flee response. And so this deep breathing works to calm that little amygdala, that peanut, calm that brain down, okay? And so it can make us feel calmer, can bring that heart rate down, can turn on our prefrontal cortex to think better, to do problem solving. And so one, it can be practiced anywhere that you feel safe, okay? Calms that fight or flight or flee response, calms your heart rate. It increases the supply of oxygen to your brain and to your body. It's free to do, and you can do it any time of the day or night if you're in a safe space. And so it's really one of the most wonderful things that we can be doing, whether we're in super high stress or even if we're doing pretty well, we feel pretty calm. It's still just another way to bring oxygen in, lower that heart rate, checking in with our body, and bringing oxygen in. So right before I presented today, I had the computer off and I was doing some deep breaths just to kind of calm that little heart rate down a little bit before presenting and joining the session. So the other thing I'll say about deep breathing is that in order to have it be a response that we do when we're anxious or we're nervous or something else is going on, we have to practice it a lot. And we have to practice it when we are not upset, right? If we want it to be our go-to, we have to make it a habit and a routine. So I just encourage you to try it, start with once a day. And if that's okay, do it, try to build up to several minutes, try to build up to doing it multiple times a day, doing it when you wake up, maybe doing it before bed, that can be really helpful. Or at times during the day, maybe when you start to feel not your best or something else is happening, maybe start doing that and just trying it and building it into your day. It really, really can be helpful to calming your brain, your body, and bringing down your stress level. All right, so you still sticking with me? Hopefully it wasn't too much. All right, we're gonna move on to some heavier things maybe, but also things that are really important to talk about. And one is that life can burn us out, right? There's regular life. Then you add COVID life. If you're living with a chronic illness, if you are the loved one of someone with a chronic illness, jobs, kids, family, friends, anything can really stress us out and can lead to burnout, right? And many of us are many things to many people. We might be spouses or partners, or many of us are parents or siblings. Some of us have children, we're employees, we're business owners, we're community members. We are a part of a lot of different systems, and we have a lot of different roles. And under ideal circumstances, we're able to balance all those responsibilities and competing roles, right? We can juggle. We're juggling, we've got all the balls, we're doing pretty well. Maybe a ball will drop a little bit, but we pick it up and we can put it back in, and we're juggling pretty well, we're making it through. However, when we have accumulating demands and the costs of life continue to overwhelm many people and can undermine a lot of the roles that we're playing, it can be easy to lose oneself to burnout. And so we're juggling, and maybe things are getting too heavy. We're not getting our best sleep. We're not feeling our best. Our health isn't good. So the juggling becomes harder. And we have new roles that come up. And we have to take on more work somewhere or multiple places. And so a ball drops, we can't pick it up. Another ball drops, we can't pick it up. And we're really just fatigued, right? And it's continuous fatigue. We just can't manage everything. And so that can bleed into feeling burned out or being burned out. And when I say burnout, what does that really mean? So to me, burnout is a state of physical, emotional, or mental exhaustion. It can be accompanied by a change in attitude from positive and caring to maybe negative and unconcerned. You might be unable to keep up with life's incessant demands or all the demands that you have. And why might burnout happen? We talked about the juggling and all the things that come up in our life and new things that are added. That burnout can occur when we don't get the help that we might need to juggle all those balls, or the breaks that we need to juggle all the balls and responsibilities. Burnout can happen when we try to do more than we're physically, emotionally, and financially able, right? And so we just can't do it. We probably shouldn't have taken on all those things for longer periods of time, and we can't get it done without help. And so that's what can lead to burnout. And when I talk about burnout, I don't mean that on a Wednesday we're having a rough day and that we didn't get the best sleep the night before, so our coping skills are lower. We're running maybe on coffee, which keeps us up and brings us down, and keeps us up and brings us down. Somebody dropped a boatload of stuff on our desk, or your kids came home with 3 projects that have to be done by tomorrow morning and there's no poster board, or you have 5 medical appointments and traffic in our area is horrible and you can't get there and you're not feeling your best and you really haven't eaten. And so you're having a crap day, right? You're just really having a horrible day. And maybe that can bleed into Thursday. But maybe by like Thursday night, you say, I'm getting a good night's sleep tonight. I'm going to bed early. I'm going to not, drink any coffee this afternoon. I'm going to watch maybe some TV that's a comedy, half an hour, get me some, get some laughter going, which can bring good chemicals into your brain. And then you wake up Friday and you feel better. And it's rolling into the weekend. So you've used your coping strategies. You've talked maybe to someone that you love or care about, gotten some support, gotten some stuff done, you've prioritized. And so you're back to almost normal, and you're moving back through, and you're doing okay with juggling the balls. So that's not burnout, that's tired, right? Burnout for me as a mental health professional and working in the medical world is when your life is negatively impacted in several ways by what's happening and what you're feeling for 2 weeks or longer. That's consistent. That's a chunk of time, right? It's not a bad Tuesday or Wednesday. It's past 2 or 3 weeks. I've really struggled, right? And so what are some of the warning signs to look for with burnout? Withdrawal and isolation from friends and family, loss of interest in activities that you used to enjoy, feeling blue, cranky, hopeless or helpless, feelings of anxiety, fear, and frustration maybe are more consistent throughout your day or days. You might even develop physical symptoms such as trouble sleeping, which can be too much sleep or too little sleep, trouble eating and hydrating, stomach aches, headaches, fatigue, maybe misuse of alcohol, prescription drugs, and or sleeping medications, or using substances that would be considered illegal. Maybe increased sick days or days where you're not getting out of bed, not leaving the house. maybe not showering, not taking care of yourself. So this is not an end-all be-all list of what burnout can look like. These are just some things to be paying attention to with your own body around how am I doing, how am I feeling, how am I managing, or seeing it in someone that you love, right? Seeing these things 2 weeks or longer, checking in with that person that you love to say, something's going on here. I'm worried about you. I've noticed these things. What's going on, right? So I think that can be important. So what are some of the things that I can do, you can do to take care of ourselves, right? Because I love action steps, things that we can try, things that we can add to our life, things that we can do to maybe fight off burnout, to fight off the stresses of the day. And I'll start with this quote that's take time for yourself every day. It's not being selfish, it's being healthy. And I see that in a lot of the patients that I talk to. I see it in a lot of friends, especially moms, right? Moms are very good at taking care, and many dads, but or say parent. They're very good at taking care of everybody else, but not necessarily good at taking care of themselves. If we don't take care of ourselves, then we run the risk of not being the best caregiver for someone else. Okay. So I'm going to talk about some ideas that will not be new to you at all. They're usually things that people don't want to hear. And putting 1 to 5 of these things into action might be the new part. But I promise you that doing several of these things will be helpful. That's why people continuously talk about it. That's why mental health providers, why primary care doctors, why your neurologists are talking to you and suggesting these things, because research shows that they tend to work. It just takes effort for us to do it, and that's typically the hard part. But let's talk about it anyways. I'll be the next person to talk to you about it. So things that you can do to stay healthy or improve your health is going to your own medical appointments. Again, if you're a caregiver for someone, often you're very good at making sure they get to their appointments, but maybe not the best at getting to your appointments, or other things come up. So it's, well, I needed to go see my neurologist, but I had to do these things. And then it took me 5 months to reschedule, right? But I know it's important to see my neurologist. So getting to your appointments, taking your own medication on time as prescribed, eating well. Boo, right? Who wants to eat well? Well, maybe we can balance out some of the stuff we want to eat with some very good things for our body. That's helpful. Decreasing alcohol and other substances. Maybe next time we can talk about what alcohol and other substances do to our brains. It's really, it can help maybe with some stress, but they're not the best for our brain. Maybe we'll add that to the list for next year. Reinforcing or increasing your support network. Who can you count on? Do you need to find some new friends? Do you need to go out with your friends? Do you need to talk with your friends or family members? Do you belong to any groups, anything like that? Getting you out of the house and getting you out of your head. Assess your own limits and your burnout level. And I think part of that breathing exercise that we did and the meditation that we're going to do, I think that can be really helpful to bring us back into our bodies. How am I doing? Let's assess me. It's not selfish. How am I doing? Am I doing the best that I can do? Okay. Acknowledging your own mental health needs, if you have them. Do you need to talk to somebody? Is that helpful? Do you need any type of counseling and support group? Another one that I love is engaging in healthy things that make us happy, like a hobby. I talk to a lot of people, I would say middle-aged to older. I don't have any hobbies. I don't know. I would have no idea what I would want to do. So sometimes we talk about, what did you love to do when you were a teenager? Well, maybe you can't do those things, but maybe you could. Maybe you need a modification. But what did you used to love? Right? So I'll do a personal story, as my brother is 45, 46. And during the pandemic, super bored. right? He would take the dog for walks, and he has a 5-year-old now, and take the 5-year-old for walks. And he says, oh, I'm just so bored. I got to move my body more. I said, find a hobby. How am I going to find a hobby? Well, what did you love to do when you were younger? Skateboarding. So my 45-plus-year-old brother bought a couple skateboards and put them together, and then has been skateboarding out in his neighborhood, learning tricks that he used to do, trying new tricks, falling. Hopefully he wears his helmet as I directed. But it gets him out of the house. It's physically using his body. He has all these memories of what he used to do when he was a teenager on these skateboards. He has a little skateboard for his 5-year-old. He's getting sunshine, getting fresh air, and learning new things to engage his brain other than sitting on his couch or walking the dog. So that's something to look back on, like, I used to do that. Or what's something that you've always wanted to do but haven't done it? So an example for me is scuba diving. I'm afraid of it, but it'll get me out of my house. It'll teach me new things. All of it just sounds like such a big challenge. So I'm learning, taking scuba classes, things like that. Photography, music. Do you make music? Do you love to listen to music? Art, playing games, cards, going to the movies, going to the gym, whatever it is, writing letters, whatever it is, find a hobby. And then potentially find others that like to do that hobby as well. Okay. Other excellent ways to decrease stress and anxiety. This is one that people hate to hear. Exercise. People don't want to do it. I don't want to do it. Got to do it. It is such good brain food. It's good for your brain. It's good for your body. It's good for your mobility. It's good for your core and feeling strong. It's good for sitting up straight. It's good for sleep. So many ways that your body benefits from exercise. And, I work in the multiple sclerosis clinic, and I have a lot of people that have mobility issues that say, well, you say exercise, Kim, I can't go run a marathon. I can't go hike in the woods. I can't, do 1, 2, and 3. I said, okay, can you do a modified yoga from where you sit? Yeah. Okay. Can you lift some light weights or heavy weights from the chair that you're sitting in, or a different chair? Probably. Can you, sitting in a chair, move your legs on, say, one of those stationary, it's not a bicycle, but like a pedal, like a bike pedal from where you're sitting? Maybe. Can you walk around your house? Yes. Okay, then you can exercise, right? So, and then I had someone recently, there's no time, Kim. There's no time in my day. And I said, how many hours do you watch television a day? And he said 2, 3. I said, if you have time to watch television, you have time to get in some exercise. He did not like that answer, but he accepted it as truth. So that's something to think about as well. It's really just so good for your brain. Spending time in nature, lots of evidence and research around how just being outside, being in parks, being in a garden, being in your backyard, just spending time in nature, getting some sunshine and some fresh air can be really helpful to the brain in terms of decreasing stress and anxiety. Deep breathing, we talked about why that can be really good for our brain and our body. Meditation, which we're going to talk about in a minute, can be really good. And also getting good night's sleep. The body, our bodies and brains typically need 7 to 9 hours. Maybe there are a few people that need 6. There are some people that need 10. But really getting sleep can be so beneficial to your brain and to your body. So again, none of these should be earth-shattering. You're like, I've never heard that. They should be like, yeah, I've heard that all before. But thinking about, how do I do these things? And if I'm not doing any of these things, how can I? And I'll just say in terms of exercise, or things that are hobby, that you want to be a hobby, but you feel as if what you're living with in terms of maybe a chronic illness or something that's going on with you physically, you feel that you can't do and you wouldn't know how to modify it, I encourage you to talk to either your neurologist or your primary care doctor to maybe get a physical therapy or occupational therapy referral. Physical therapy can help you create a list of exercises that you can do safely, and then potentially increase those exercises as you grow stronger. And also, I would say for the occupational therapy, they can look at activities that you want to do and help modify those so that you can do, if cooking is your thing, but you're having trouble standing, maybe to cut all the stuff up or use knives, use this, whatever, they can help figure out a way that you can do those things in a different way, but still accomplish the goal of, say, cooking. Okay. So I encourage you to talk to someone if you feel like that you're hindered by something physical happening in your body. Okay. We're going to move on to meditation. And meditation is a practice of focus, concentration. It's bringing yourself back into your body and keeps you in the moment. All right. So there's benefits of meditation, such as decreased stress and anxiety, depression, heart disease. It can help falling asleep. It can help you increase your focus. There's so many things that you can do with meditation, again, to calm the brain, calm your heart rate. There's different types of meditation. What I'd like to do with you is a body scan, just real quick, just for a minute or two. And we'll do a body scan that I actually do with patients at Georgetown via Zoom. And so I encourage you, you don't have to do it again if you don't want to. I encourage you to, if you feel that you can in your safe space. So it's kind of have your feet on the floor, hands with your palms open, sitting comfortably wherever you are. I invite you to close your eyes because it will shut out visual stimuli. All right. And so we're going to start with that breathing, long, slow breaths in, and those slow breaths out at your own pace. And we're going to actually we'll just do the head because I've talked for a long time, but we're going to focus on our shoulders. And so as you breathe, visualize your shoulders, roll your shoulders slowly up towards your ears, bring them down towards your back and your chair, bring them down as far as you can. Do that one more time as you breathe. Slowly raise them to your ears. Bring them back towards your chair and down, away from your ears. Very good. As you continue to breathe, I invite you to move your neck, right, your head from side to side very slowly. If you have any pain, don't do it or stop, but just move from one side to the other as far as you can go and feel that tension or pull, that stretch in your neck, and then slowly move to the other side. Feel that stretch, come back to neutral, slow breaths in and out. With meditation, you're checking in on your body. How did that feel? Do I have any aches and pains in my neck and shoulder? Anything that I need to think about later? Anything that I may have to come back to? And then with your face, just imagine your eyes are closed gently, not scrunched. Your cheeks are calm. Your lips are not scrunched together. They're just gently closed. Feel that breath coming in and out. You feel that breath going into your lungs, expanding like balloons. Feel that breath all the way down in your belly. And you feel that breath going back out of your body, from your belly to your lungs, out your mouth. The oxygen is going to your brain, into your cells. Do one more big, long breath in. And then pushing that breath all the way out. Very good, very good. So open your eyes if you had them closed, come back into the room. All right, I'm gonna finish up here, but I also wanna go into, sometimes we need help, right? We talked about burnout, talked about ways to calm our bodies down, to take care of ourselves, but life is hard. Life can be burdensome, and sometimes we need help. And I hear from many people, I don't want to be a burden to anybody. I don't want to worry anybody. Well, this is the nature of being human. I would say that many adults, we spend decades helping others and helping our communities. And think of your own life. Who have you helped? Who have you lightened someone else's load for, right? And why is it hard for us to accept help from other people when we need it, when we spend so much time helping others? That's an individual question to ask, and something that I challenge you to do some reflection on, but also to know that it's okay to ask for help. And I will acknowledge that not everyone has an extensive network, and not everyone can afford out-of-pocket care. Not everyone has friends and family that do want to help or can help. I know that that exists, and you may have to rely on some government agencies, maybe more on your medical system, things like that. But for a lot of other people, we do have people in our life that do want to help, if we just give them that opportunity. All right. So sometimes, though, we need more help, and we need help from a professional. And so I encourage people to be thinking about their mental health. How am I doing? Am I burned out? Do I need to talk to somebody? It's so important to take care of ourselves if we want to take care of other people. I put a list up here in terms of individual counseling, some of the cultural competency. So there's therapy for Latinx, there's Black Mental Health Alliance, National Asian American Pacific Islander Mental Health Association, We Are Native, LGBT National Help Center. I'm a big fan of support groups as well. There's support groups for epilepsy, there's support groups for caregivers, there's support groups for neuroimmunology issues, there's support groups for being a single parent. You pick a topic, there's a support group. And these days, support groups are usually free, low cost, and they're often easier to get involved in than individual counseling. The mental health world is extremely stretched and overwhelmed, so it can take a while to find mental health individual, group, or family or couples counseling. The best place I tell people to start is getting a list from your insurance company, but know going in that it's going to be difficult to find somebody. So support groups may be a bridge for you to get some help. Last slide, I promise. I know Kira's probably thinking about, we got to go. Just summary. Taking care of yourself is essential. Making wellness a routine will change your brain. It'll help your body. I encourage you to practice deep breathing, meditation, exercise, and getting good sleep. And I thank you so much again for having me. I really loved being here. And I hope that you have a good rest of the time today at the conference. Thank you.
Kim, this was awesome. Thank you so much. And you hit on so many topics that I think are just so important, not only for people living with epilepsy and their caregivers, but really everyone, between COVID and the pandemic and, life's challenges, the things that you talked about and the tools and the skills that we can use, I think are cross-cutting for anyone. And I really, Really appreciate you coming. We have a few comments and questions. So one of the questions that we have here, just a second. How is burnout different than depression?
So often they have the same symptoms. And I think that a psychiatrist would be the best person to kind of figure out what's really happening. Because burnout is things that we're just like, lots of things are happening. We're having trouble juggling those balls. Depression, actually, I look at it as the clinical depression is often chemical imbalance in our brain, right? And so that needs to be addressed or at least acknowledged. So feeling tired, can't juggle all those balls versus we still can't do that in depression. It's often very hard, but also there's probably a chemical imbalance that's happening or something else that's happening. So either way, if you feel like, is this depression, is this burnout, talking to a mental health professional, your primary care, is a great way to start. And then they can narrow down, do an assessment, and try to figure out what's happening.
Okay, great. Thank you. A couple other comments. Wow, this was great. Thank you, Kim. Great job. And then support groups work. I am a witness. That's how I found out about this event.
Mm-hmm. Yeah, for sure. And again, especially because it's so hard to find individual therapy, support groups are a way that a safe space that you can hopefully share what you're feeling, support other people, which often boosts us up, right? When we support someone else and encourage them, and maybe get some tips on how are you coping? Oh, maybe I'll try that, right? And another way to encourage other people as well is like, hey, this worked for me. I don't want to get up and do that walk every day, but I do. And that has shown to work over time.
Great. Kim, thank you so much again. I hope you have a great rest of your day.
Great. Awesome. Thank you so much for having me. Thanks, everybody.
All right. So up next, we're going to hear from Amanda Ventura Zink from the Waymo company, and she's the public affair manager for Waymo, and that's an autonomous driving technology company with a mission to make it safe and easy for people to get where they're going. She leads the world's first public education campaign for autonomous vehicles called Let's Talk Autonomous Driving, of which the Epilepsy Foundation is a partner, educational partner. So Amanda's going to share a brief introduction to autonomous driving, Waymo's work over the last 13 years, and a look at how it has potential to affect the epilepsy community. So Amanda, thank you so much for being able to join us today.
Yeah, thank you so much, Kira. And thank you, Kimberly, for leading us in that meditation. That was just nice. I think I want to do that from now on before any kind of presentation. So hi, everyone. I'm on the public affairs team at Waymo. As Kira said, we're an autonomous driving technology company. And it's our mission to make it safe and easy for people and things to get where they're going. I am going to share my screen as soon as that's allowed. I know that it takes a few seconds to kind of switch between sharers. Oh, there's Derek. So if anyone watches Veritasium, Derek, the host, he came out to our facility in Arizona and did a tour and a ride along, and he talks a little bit about something that's really near and dear to my heart, which is building trust in the communities where we operate. And so understanding, how do we get people to, embrace technology? How do we get people to want to get into a vehicle where there really is no one behind the steering wheel? And how do we, think about people getting into a car that has no steering wheel, no pedals, long term? And one of the things that he talks about in his video is quite entertaining, which is the thought that back, when elevators were new, there were actually elevator drivers. And, the idea of an attendant being there was something that people were terrified about, that attendant actually leaving. And so for a while, like the first driverless transportation was actually elevators. And for a while they were talking about like driverless elevators, which now we think, you know, that's wild, that's madness to, you know, need someone to push the button for you. But that is, you know, kind of what we're thinking long term. You know, that's probably going to be the sentiment around, you know, driving your own vehicle at some point. So very, very far in the future, but, you know, just a little fun historical context that Derek had worked into his Veritasium episode. All right, I still don't see the ability to share my screen, Kira. So I'm going to, let's see if that. I wonder if I have to be made the host. Oh, there we go.
I did make you the host, yes.
It looks like it worked.
Okay.
Okay, microphone's disabled. Can everyone hear me and see me?
Yes, and we can see your screens.
Beautiful. Okay. All right. So as I said, we're building the world's most experienced driver. This is a couple of the vehicle platforms that we have. I'm going to focus on the two vehicles in the front here, but we are, you know, applying this technology to a variety of vehicle platforms, including semi-trucks. So at Waymo, we're building the world's most experienced driver. Our name, how do we come up with it? That's always the first question I get. The name Waymo is kind of a portmanteau. So it stands for a new way forward in mobility. And we really think that this technology has the potential to save lives, increase independence, and then improve access to mobility as well. And, you know, we think that this technology can be applied to a variety of use cases. So driving is not as safe as it could be. There are 40,000 deaths every single year on our nation's roadways. That I think the statistic is somewhere like 94% of those accidents are caused by some kind of human choice or error. So that's driving drowsy, driving drunk, driving distracted, driving angry. And on top of those, you know, 40,000 deaths, many of which are preventable, there are also 50 million injuries worldwide. And about half of the deaths worldwide involve pedestrians, cyclists, motorcyclists. We're not even talking about, you know, people in vehicles themselves. So this is a really important statistic in our journey as a company, where we had a bunch of really smart people at the Google X lab in California, and they were saying, how do we make what is a, you know, issue in our culture that we could try to solve through technology? And we decided, hey, we could probably help prevent a number of these unnecessary deaths and injuries. So over the last 13 years, we have driven more than 20 million miles on public roads, more than 20 billion in simulation, and then we've tested in more than 13 US states, including places on the East Coast and the West Coast. And during that time, we have logged what is kind of similar to 1,000 years of human driving experience, which I know is kind of a pointless number because it means nothing to us. But when you think of it from the perspective of, you know, the things that you or I might experience, or when we're, you know, on the roads, imagine that like times, you know, a factor of 100. And that's, you know, the kind of experiences that our technology has encountered, whether that's in simulation or in the real world. So I've said the word autonomous a few times. I like to just go through what's considered the levels of automated features inside of vehicles that are on the road today and the vehicles that are in the technology that we're developing at Waymo. So the Society of Automotive Engineers put this together. There's essentially 6 levels. A level 0 where you're doing all the manual driving, which doesn't really exist anymore on our roadways. Levels 1 through 3 and a little bit into level 4 requires a human driver, someone with a license, to touch the steering wheel and take over at some point. So this could be, you know, technology features such as cruise control, you know, even the self-park feature, like anything that, you know, makes your car smarter and does something for you, that falls into what we call driver assist features. So it's still automation, but it's not autonomous. Fully autonomous technology is where someone who is blind, someone who does not have a license, someone who cannot drive due to impairment can get into the back of a vehicle and it, with no one else in the car, no one needing to touch the steering wheel, and go from point A to point B without ever needing to do any of the operations related to driving, other than maybe open the door for themselves. And so that's full autonomy, and that's what we're working on at Waymo. Something that Kira mentioned is our public education campaign. So this is new technology. This is a new use case. So it's really important that we're working with organizations in the disability space, in the safety space, in the space of, you know, future of work. So we partner with organizations spanning this huge gamut of interests and talk to them and say, how can this technology be applied to the people that you work with? How would they want to use it? And it's really important that we do this now before our technology is launched widespread, because it doesn't make sense to launch a service or a technology and not have the points of view of everyone it's going to serve involved in that development. So some of the groups we work with are the Foundation for Blind Children, Foundation for Senior Living, the Girl Scouts, AAA, Mothers Against Drunk Driving, as well as the Epilepsy Foundation in Arizona and Northern California. Okay, so quick little terminology bit here. The Waymo driver, when I say that, I'm referring to technology, so not a human driver. So I know it can get a little bit confusing, but when I say Waymo driver, I'm referring to our sensors on our vehicles. I'm referring to the technology, the artificial intelligence computer system, all of that. So not talking about a human when I say Waymo driver. All right, so this driver, as I said, can be applied to different vehicles. And there are a lot of components. So I'm going to walk you guys through just a few of the more important ones, because if anyone has seen our technology in real time, they know there's like big, crazy spinning sensors, and there's, you know, cameras and like these boxes on the outside of the vehicle. And so I think it's really helpful to walk through the hardware, all of the stuff that you see on the outside of the vehicle that, you know, makes it a little distinctive from other vehicles on the road. We built all of this in-house as well. So all of this technology, the software and the hardware is all built by Waymo and then applied to the vehicles at its Detroit facility. Okay, so the Waymo driver has three basic external components that you can see here. This is the bird's eye view, and I'm going to walk you through each of them. So LiDAR, this is probably one of the most interesting sensors on our vehicle because it's the spinning sensor. It's what gets everyone's attention. And what LiDAR does is it helps us see in 3D around us. LiDAR is short for basically lasers. It's like a laser sensing radar. And it sends out light pulses into the world around us. And it kind of creates this, like what we call a point cloud that lets us see a vague outline of what's around us: trees, people, curbs, all of that. And then that is paired with a overlapping field of view of cameras. We have 29 cameras on the exterior of one of our electric Jaguar I-Paces. And that helps us see in color, right? So that's important when we're thinking about changing traffic lights. Our radar helps us, and this is something that a lot of our, like if you own a personal vehicle or you know someone who does, this helps us with depth perception. So you'll see radar engaged notifications if you have a vehicle that has cruise control. Radar is what they use to figure out, you know, how far the vehicle is in front of you. But we use radar for, you know, 360-degree awareness to say, you know, how far are we from this bush off to our side? Or what is the distance between objects, you know, around us? And so all of this tech, all of these sensors help us see in 360 degrees around us. So that means we have eyes in the back of our head. And it helps us see up to 3 football fields in every direction and in full darkness. So this also means we can drive at night, no light needed. Okay, so for the software side, this one takes a little bit of explaining in terms of, you know, how the sensors on the outside use all this information that they get to help us safely navigate the world around us. Okay, so basically the software has to answer 4 key questions. And this is the same for anyone who operates their own vehicle anyway. The first question is, where am I? So before we can drive anywhere, we have to create really detailed 3D maps. And so the sensors on our vehicles run in real time while a human operator is in the vehicle. And we're looking at everything from curb height, stop signs, bike lanes, crosswalks. And we're trying to collect as much information about the driving world that we're going to need to know in an area where we're going to have the Waymo driver behind the wheel, so to speak. The next question is, what's around me? So once we know where we are, we have to be able to figure out, what's going on in the world. And so in real time, our sensors are, looking at the pedestrians, they're looking at the other road users, the vehicles. We're looking at real-time information such as temporary stop signs or, traffic lights. And so all of our sensors are helping us take in that real-time information. And we also have to be able to identify all these pedestrians. We all look different. We all walk different. We have different gestures. We have to be able to identify all of them as pedestrians. And so we use something called machine learning that helps us say, here are the basic characteristics of a pedestrian so that we can essentially identify a pedestrian as a pedestrian, even though we've never seen them before. And the same goes for, different types of bicycles or, other wheeled contraptions, which we test in San Francisco. And I can tell you, there are some things where I'm like, is that really a bike? But yes, it is, and we can tell. Okay, so we know where we are, we know what's around us. Now we have to do something really complicated, which is what's going to happen next. And so using speed and trajectory, we can predict, what the vehicles around us are going to do or what the pedestrians are going to do. And then this helps us decide what's the safest route for us to, take to continue on our journey. Okay, so I'm going to play this out with you guys in this very quick 8-second video. This is going to show you someone running a red light. The video that you see is from the perspective of a human driver, so to speak. But in the vehicle, I'm going to show you how the Waymo driver approaches the situation. Okay. All right, so let me break that video down for everyone. So this little screen in the corner that you see is what you guys just watched. I'm going to break it down by a few frames. What you see on the big black and white photo here is kind of a crude representation of what the Waymo driver sees, the technology. So right away, we can see that we are heading toward a green light in an intersection. So we have the green light, human drivers thinking, let's go. What we noticed though, as the Waymo driver, and what we can see as the human is, okay, yeah, cross traffic is stopped, right? But the Waymo driver can actually see a little bit farther out, and it sees a vehicle that is actually not decelerating, which would be the expected behavior as someone approaching a red light. So what we end up doing as a Waymo driver is we set up a big red barrier and we say, do not pass go. Like that, we predict that this driver that's coming toward the red light is actually going to run it. And they do. And what we do, and it's a little difficult to tell in the video, is in this process of us sensing this person who's speeding up, our technology actually already starts slowing down just enough to where we can keep going through the intersection. It's not like we're going to do a hard brake and stop, but we adjust our own speed so that we're not impacted by this person who's running the red light illegally. All right. So how do we apply all of this technology? The exciting thing about where we're at right now as Waymo is that we actually operate the world's first fully autonomous public ride hailing service. Okay, whatever, a bunch of jargon. So what that means is that if any of you use ride sharing apps, we have the same kind of service, except a completely empty vehicle comes and picks you up and takes you where you want to go. And you do not have to drive the vehicle. You do not even necessarily need a license. You just have to be 18 for the time being to get into the vehicle and go where you need to go. It's also within a specific service area, so I'll get to that in a little bit. But these are the two vehicles that we currently have in our service. And the service is called Waymo One. Okay, so here's the app. It's public, so you can download it on Google Play or the App Store. Right now, our public service is only available in the Phoenix East Valley. So I know for the East Coasters on this call, not ideal, but I will share that we have tested in more than 13 cities, and I will get to that in a little bit. But as you can see, the UX, or like the user experience here, is pretty straightforward. You would enter your trip details and then you request a ride. It gives you an estimate on pricing, an estimate on wait time, and you get to interact with, and see where the vehicle is on its way to you. When you get into the vehicle, there's a screen that can give you different layers of information, or you can just play your podcasts, or you can give us real-time feedback, or you can switch the different views. We really tried to make it applicable to different levels of comfort. This darker view that you can see popping up every few seconds, this gives people a glimpse into what the Waymo driver sees without overwhelming them with too much information. So when you're in the vehicle, you can see like, oh yeah, I see that traffic cone, or oh yeah, there's that person walking their dog, or there's the person jaywalking behind me. And so you'll notice that. You'll see that we can pick up other trucks and they show up as bigger than the smaller cars. So we find that this is a really great way for people to understand the technology and what it's picking up around us. I already kind of mentioned this one, but we have been operating this public service since late 2020. So this has been around for a while, and we've been testing with public riders since 2016. And we are expanding more quickly. So in addition to the Phoenix East Valley, we also are in the testing process in San Francisco, where we have public riders who are part of a beta testing program, which is the next phase before we open it up to the public. That's just where people are giving us feedback. And then in downtown Phoenix, which is about, I would say like 25 minutes west of the Phoenix East Valley, we're also expanding there. So we're tackling more of these dense urban areas. All right, so last year we also did what we call core sampling or mapping in New York. And this is this area where we were mapping and testing in New York. Really interesting, challenges there. The most populous city in the country, a lot of pedestrians, a lot of gridlock traffic, and then really interesting weather scenarios. And so that's what we're really looking at, when we're testing in some of these other areas like Miami or New York, or even in Detroit, is snow and rain and, all sorts of levels of, weather that fall in between all of that. And then just lastly, before I open this up to questions, I want to share the story of a young man, and sorry, the words are cut off, but I promise the video will be okay. I want to share the story of a young man named Brennan, who lives in Phoenix, Arizona. And he has epilepsy, and he took a ride with our Waymo One service and shared some of his feelings and insights being inside a vehicle as a young adult, that he's not driving. And I'm going to just make sure that I go on mute, and then this.
I've lived in Phoenix my whole life, born and raised. I was diagnosed with epilepsy at the age of 8. I was having seizures over and over again, and my seizures at that time in my life were very bad, and I would stop breathing.
Epilepsy is a disorder that is characterized by seizures.
1 in 26 people will get epilepsy, and 1 in 10 will have a seizure in their lifetime.
My current seizure isn't as intense. My leg will stiffen, and after about 20 seconds, I go back to normal.
Independence for somebody with epilepsy is a huge deal. People with epilepsy are told no a lot. No, you can't go to that party. No, you can't be in the sun too long. No, you can't drive. No, you can't even take a shower by yourself. They lose a lot of independence if they're not under control with their seizures.
Like knows my name.
I know, I love that. I feel like I'm in a spaceship in like a good way.
Usually I have to get rides from like sisters or my parents.
I've heard stories from other people with epilepsy about how, like, when they've taken public transportation or any sort of transportation that had a driver that didn't know them, that they felt like they had to say, okay, just so you know, I have epilepsy, like, this is what might happen. If this happens, do this, don't do this. Like, have you experienced that before?
I'd say the worst experience that I've had like that was actually, they didn't charge me for it, but they were like, oh, you have epilepsy, I don't feel comfortable giving you a ride, and I was really angry. It almost eats away at my sense of pride of wanting to be self-sufficient.
So I think that autonomous driving holds a lot of promise for people with seizures. Most people with epilepsy are fine 99.9% of their lives, and they have seizures once a week, once a month, once a year. And because of that, they may not be able to drive. And so that really can create quite a problem for people to work, to have a social life. And so having the ability to do that and not have to rely on other people, I think would be potentially life-changing for people with seizures.
And we're back. That is door to door right there.
It is.
This is really cool.
All right, so that is it for my presentation, but I do just want to stress that, Brennan is probably one of our top videos for the Let's Talk Autonomous Driving campaign. I want to say he's at like 1.3 million views at this point. And I think it's because his story resonates with so many people. And I'm just really excited to, engage with the Epilepsy Foundation and its community members. This is a pretty new partnership for us. It's about a year in, and I'm excited to hear your guys' questions. Thanks for having me today.
So we do have one question, and it asks, is this similar to GPS technology?
Oh, good question. So if you're asking if it's the same as Google Maps, it's not. But we do use a type of GPS for that, number one question, which is where am I? But we use a lot of additional information as well. The Google Maps don't have the kind of detail that, our technology would need in order to operate safely in a, ever-changing environment. We need to know that curb height. We need to know, the details of the road in a way that our sensors can, understand as well. But great question.
Great, thank you so much. I don't see any other questions in the chat box, but I have to say this technology is so interesting, and really what an impact it's going to make in the future, not only for people who are living with epilepsy, but really anyone who has the challenge of transportation. I'm sorry, one other question popped up. What are the possibilities for making available outside of the US, such as the Bahamas?
Oh my gosh. Well, I'll be advocate number 2 here for the Bahamas, because that sounds like a fun place. Probably with some interesting weather, I can imagine as well for us to think about. So right now we are focused on our services in the United States, but that's not to say that, I think it was our co-CEO, Dekedra Mawakana, she was recently doing an interview with Bloomberg, and the interviewer had said, well, where's next for Waymo? Like, where are you guys going to explore next? And her answer was everywhere. And so I think that sums it up. Like, ultimately, we see this technology as being completely transformative for the entire world. And we need to, it's just a matter of rolling it out to the whole world and getting that buy-in from everyone who, helps either regulate or helps, wants to like get into a ride for the first time. I mean, there's a lot of these, additional steps that have to be taken. But our team is really focused on this being, a widespread service that's available and usable by everyone.
Well, I'll tell you the analogy that you used about the elevator operators. I mean, it just makes so much sense. So, maybe 20 years from now, autonomous driving is everywhere and it's just the norm. So be interesting to see.
Yeah, likewise. And we want you all along for the journey. I think that's the most important thing. So I guess if I can say one thing, we have a public education campaign where we do a newsletter, where we're sending out videos like Brennan's, or, we're publishing the most recent updates from Waymo, or just even thought leadership, like from the National Sleep Foundation, talking about like, what is the potential of this technology and what are some of the things that, maybe people don't think about. I think that, for the average person who, maybe doesn't know that they know someone who has epilepsy, they probably aren't thinking about, the millions of people who, lose their license, and all of a sudden they're like, oh, how do I get to my job every day for, the next 3 to 6 months or 9 months or however long, it ends up being. And so I think in the conversations I was having with Dr. Brennan, Dr. Herman, who you see in the video, she ends up doing a lot of counseling as an epileptologist about, for young adults who, maybe could drive and then have their license taken away. It's, Denison, I agree. I think there's a lot of barriers, right, that we, as two different communities, have to overcome together. Let me get that YouTube link for you. I'll send that over in a sec. And then I will also drop in the website where you guys can subscribe if you're interested to the newsletters that we send out about the advancement of the technology. All right, Brennan. Oh yeah, he's at 1.5 million.
So
all right. By communicating. Sorry about the ads, guys. Is it too soon to predict if Waymo will be more or less expensive than Uber or Lyft? Yeah, that's a really good question, Sarah. So in the Phoenix East Valley, where we do have the public service, I would say it's pretty comparable right now. But that said, you're not tipping the driver and you're not dealing with surge pricing. And so we actually do see an increase in people who are using our service when Uber or Lyft have surge pricing. And we're also looking at, different pricing models. So we've done subsidized rides with the paratransit service in the Metro Phoenix area called Dial a Ride. And with that, we actually did a 6-month pilot that was used as part of a study that the Federal Transit Authority and Arizona State University published. And what they were finding is that when individuals who normally use paratransit as their main mode of transportation were able to use the autonomous driving tech, they were going out more, they were staying out later. So between midnight and 4 a.m., they were using our service. And so we were finding that people were actually living their lives a little bit more when they had access to autonomous driving tech. And then Sarah, I see you have another question. Okay, that's a good question. So she asked, is Waymo using gasoline or electric cars? So our Chrysler Pacifica minivans, the one that you saw Brandon get into, is a hybrid. And then we are currently switching to an all-electric fleet. So we also have a Jaguar I-Pace that is in our fleet in San Francisco and in downtown Phoenix. And then eventually will be part of our fleet in the Phoenix East Valley as well. So those are all electric. We charge them. And it's a smooth ride, and it's good for the earth. So, and I think that's it for questions. I'm going to just drop in ltad.com for the public education campaign. Great. Well, thank you so much for having me, Kira. And what a great what a great event. I'm gonna like
you.
take all those meditation tips and use them forever.
Yes, we all will. But thanks again so much for your time. And this technology is just amazing. Can't wait to see what happens in the future with your organization. Have a good day.
You too. Bye.
All right, everyone. Well, it's hard to believe, but we're coming up on our last session of the day. And I would like to introduce Dr. Mary Mitzi Payne. She's a professor in the Department of Neurology at Marshall University in Huntington, West Virginia. She graduated medical school from Emory University School of Medicine. She did her residency at Louisiana State University School of Medicine in pediatric neurology. And then she also did her fellowship there in pediatric neurology. After her fellowship, she moved to Huntington, West Virginia, and has been practicing at Marshall University ever since. She's excited to be a part of the Epilepsy Foundation's mission. And today we're talking a little bit about what's new in epilepsy treatment. And she's going to talk to us a little bit about medical marijuana CBD. So if you give me just a moment, I'm going to be advancing slides for her. So I just need to pull them up. So thanks, Mitzi, for joining us today.
Thank you. Thank you for having me. I appreciate it. Sorry for the technical issues, but I feel like that's how my life is every day. So I'm glad that you can do the slides for me. This topic, I think, is everyone's excited about it and interested and kind of wanting to know more about it. And actually, as I was trying to learn more about it myself for this talk, I realized that there's really not much about it that we do know. So, and I'll be getting to that a little bit. Okay, great. So, medical marijuana. All right. And I have to say, hold on a second.
And can everyone see the screen?
Yes. Okay.
Okay.
And excuse my dog. We're trying to keep him quiet. All right. And I have to say there's some great graphics for this topic. So it's definitely fun and colorful. So what is marijuana? Well, it is technically the dried flowers of what's called the Cannabis sativa plant. Now, there are other cannabis type of plants, like 5-6 others, but this is like technically when you look at the FDA and the National Institute of Drug Abuse, this is what they're using as what is marijuana. So this was kind of already one of the parts of like, well, what is it? And are there different species from different parts of the world and different ones that people are growing? So there's just, of course, a lot of kind of mystery about this whole thing as well. So we're going to stick to the definition of it just being from the Cannabis sativa plant. And the main psychoactive ingredient is called THC, which is the long word is 9-tetrahydrocannabinol, obviously shortened to THC. However, there are many other chemicals found in the plant, and those others as a group are called cannabinoids. So it's kind of like there's THC and then there's everything else, and everything else is just lumped under cannabinoids. So it's basically the THC chemicals and the non-THC chemicals. So the THC causes, of course, happiness and relaxation, but also some anxiety, fear, poor judgment, and all of those that come with it. All right, I'm back. Okay, so marijuana is very old, and there are remnants of it found dated back to 3000 BC in Asia, Egypt, and India. So it's a very old plant, or it's a plant that's been used for a long, long time for its medical and psychoactive properties. So next is hemp. So what is hemp? This is something else we all hear about. And you even see it like hemp cord, hemp bracelets, hemp seeds, hemp milk, you know, like definitely this is like a product that we're starting to see in the stores now. And what is hemp? So hemp is actually the same species. It's still considered Cannabis sativa, but it is different than the other cannabis sativa that's called marijuana. So this one actually looks different as well. It grows taller. But this one is a little bit older. They found traces of its use back from 8000 BC in Asia. It's also used for pottery, food, medicine, and paper. So hemp actually has a lot more uses than marijuana does. I mean, sounds like you could really make your house and run your business with hemp and eat it. So now, in order for it to be grown in the US, you need to be licensed, and you have to, of course, apply for that license and show that you're an authorized grower and you have what's needed to grow it. And then the product is tested. So of course, they don't want you to kind of be hiding marijuana growing in a hemp field. So they're going to make sure that it continues to be hemp. Most people will grow it from hemp seeds, like you can buy the seeds, or even a transplant from like another hemp plant. It does best in humid environments, but with like a lower temperature and a soil rich in nitrogen. So actually it's in West Virginia, there's been a lot more hemp growers, and I think our climate is pretty conducive for that. And so but in 1957, it was classified as a marijuana product. So in the 50s, there was kind of this pushback against marijuana. And so the feds just said anything that's related to it, it's just all legal. It's just, we just don't want any of it. So it was made illegal in the 50s, which kind of put back hemp production and hemp availability for other things because it was illegal. Okay, so next slide. Can you tell them apart? Apparently you can. So marijuana has denser buds and it's a more bushier plant, and hemp seems to be taller and has thinner leaves. So I guess if you know your products, you're going to be able to identify the difference. Both have THC and CBD, but at different amounts. So this is the part too that's a little bit like tricky, and you might hear different lingo and different words talked about, or the same words talked about different things, is that hemp is any cannabis product that has less than 0.3% THC. So marijuana has the THC in it, right? And also CBD. But the hemp has more CBD. And so percentage wise has less than 0.3% THC. So really any product that has less than 0.3% THC can be considered hemp. So interesting. Even if it's like made from the lab, it's hemp. So next slide, effects of THC. So how does it work? So the THC molecule binds. So we have cannabinoid receptors in our brain. Amazing. It's part of us. It's part of humans. That's kind of why we get a euphoria from marijuana. If we didn't have these receptors in the brain, people way back in the day would have smoked it and been like, what's the point of this? So we have these receptors. There's CB1 receptors and CB2. So CB1 are in these areas of the brain that I show you. The cortex, hypothalamus, basal ganglia, cerebellum, hippocampus. But what is really kind of the target and what produces that relaxation or euphoria is usually the hippocampus, amygdala, frontal cortex. And the basal ganglia is also involved in dopamine release. So that's what can kind of increase the dopamine. And then, of course, that's part of our pleasure sense, and that can then lead to addiction. And also the amygdala also does fear. So marijuana might make some people kind of calm and not worry about things, but other people might have the opposite effect and might have more anxiety and more fear. So, as we know with any drug, the efficacy is variable based on the person, but that's where THC binds. Now we have the next slide. We have the system is called the human endocannabinoid system, which this was news to me. I didn't remember learning this in med school. So I was like, really, we do have this. And this is actually, there's a lot of studies on this, and even in animals as well, like in dogs. That's like another big topic I found, is that the dog CBD and stuff. So we have similar molecules in our bodies that bind to the same receptors that THC binds to. It's those CB1 receptors, which makes sense because otherwise we wouldn't have the receptors if we didn't have molecules to bind to them. So one example is called anandamine. That's something that our bodies make and binds to these receptors. So what happens is when THC is introduced to the body, it will bind to these receptors and not let the anandamine bind. So it blocks the effects of it and makes its own chain of events. And then this ultimately leads to increase in dopamine in the brain. And that's what we see. It kind of changes the state of the brain, whether it be a euphoric change or energy change or fear, whatever it may be, that psychoactive change. So CBD, however, the cannabinoids, remember there's like lots of these, it's just a big class. Cannabinoids do not bind directly to CB1 receptors, but indirectly they work to lower excitatory neurotransmitters. So next slide, Kira. This is a picture. It's a little on the complex side, but this was, and so there's a lot of research still looking at how does CBD affect the brain? How does THC affect the brain? There's still a lot of it that we don't know. But this was a proposed action of how CBD helps epilepsy. And this was published in Epileptic Disorders Journal in 2020. So if you look at the picture, you can see here's a neuron. The one on the top is called the presynaptic. The one on the bottom is the postsynaptic. And that opening in the middle is called the cleft. And that's where like the presynaptic neuron will be activated and will secrete neurotransmitter and then they float across the space and the synapse and bind to the receptors on the postsynaptic neuron. So you can kind of get that visual. So what happens is when CBD is in this environment, CBD, you see the little stop signs pictures. It's a 1, a 2, and a 3. That represents the CBD molecule. So they've actually found that it interacts with several different receptors on the presynaptic membrane. And then leading to further cascades, very complicated processes. But the end result they found is that it decreases excitatory neurotransmitters, which will decrease seizures. So that's pretty exciting to find that. And that's why it seems that the CBD helps epilepsy more than just like THC. It's really the CBD that helps. It's not that we're trying to get rid of people's pleasure and THC. It's like legitimately the CBD is what helps. So, okay, so marijuana uses medically. So next slide, please. So we have Marinol that's been around for a while, and that's used for nausea with chemotherapy. Also helps with appetite in cancer patients, and it has also been used in AIDS patients. So Marinol's been around for a while. I have to say, in my experience, it's very difficult to get it prescribed and approved. It's more of a situation that might be like in a hospice treatment or of course, someone with cancer. Sativex is something I found that is being used in Europe. And that is a mouth spray for neuropathic pain, like in patients with multiple sclerosis. So I thought that was interesting. So we'll probably be hearing a little bit more about that as it comes across the ocean to us. And then we have Epidiolex, which is, we all know that is the seizure medication. And that's CBD only. The above ones that I mentioned also have THC, but the Epidiolex is CBD only. And so these formulations are derived from natural plant compounds or created artificially to mimic those compounds. The good things about these is that they are FDA controlled, regulated. They're going to be made in a lab with reliability and consistency. All right, so let's talk about Epidiolex now. So next slide. It all starts with this little girl named Charlotte Figi. You may have heard of her. She unfortunately only lived to the age of 13. She was born in 2006. She died recently in 2020. They think she died, she had a lot of seizures, and she was in and out of the hospital with pneumonia, and they think it may have been COVID related. So it was like in March of 2020. But she was diagnosed in 2009 with Dravet syndrome. So she had hundreds of seizures a day. The parents had heard about another child with Dravet at that time who had a benefit from a high CBD, low THC product. So the parents started finding this product or buying this product that their friend was using, but they eventually ran out of their supply. And that's another concern with just kind of buying a product. Like if it, like over the counter, if it works, okay, good. But are you always going to have that product available to you? So of course they ran out of the supply. And so they approached these brothers in Colorado who were growing different plants to make it for them. So that brings me to the next slide. So these brothers in Colorado in 2011 made a compound high in CBD and low in THC by crossbreeding strains of hemp with marijuana. Now, this was separate from Charlotte at this point. They were just doing it on their own. And it was actually known as the hippie's disappointment because it did not produce a euphoria. So, but they found that other people were using it for other medical uses. So Charlotte's parents found out about them as well. And so they approached them to make a strain for their daughter. So they did. So they made it's high CBD. And of course, the THC is less than 0.3%. Which is that key number of making it a CBD product and not like a marijuana product. And they called it Charlotte's Web in 2014. And Charlotte's Web was probably the first CBD product I was hearing about from patients. And they were able to buy it online. But back then, depending on the state laws, they might not have been able to have it in their state. So sometimes people had to go to Colorado or ship it to a state with laws that allowed it in the state, and then just basically hide it, from everyone that they were giving it to their child. So fortunately now that is not an issue. And so it has been very much available. Okay, so Epidiolex history. So meanwhile, this came out, Charlotte's Web came out in about 2014. And around this time, lots of centers, large epilepsy centers were wanting to study CBD. This Charlotte's Web seemed to make this amazing difference in this young patient, Charlotte. And so everyone wanted to help. Everybody wanted an improvement for these children with debilitating epilepsy. So meanwhile, you'll see a lot of these laws are changing. Congress is changing. Legislatures are listening to their constituents because people are saying, look, we want to use this medication, but it's not legal. I need this for my kid. And how can say no to improving the life of a kid? And so there was a lot of pressure. So in 2018, it was called the Farm Bill. And what it did is it made CBD products can be studied for medical use. This was huge too, because we couldn't even study it. Like not only was it taboo for the families, but folks in the lab couldn't even study it, and look at its processes and how does it work and how is it safe or not. So that was a huge improvement. So hemp is high in CBD naturally. So this also opened up for hemp. Remember I said in the 50s, hemp was made illegal. Well, now it's made legal to be studied. The product has to be less than that 0.3%. That's the key number. And obviously THC is a psychoactive component. So Congress didn't want this to be used or studied. But we all know that studying THC itself is also going to have some benefits to us. So we understand how it works and maybe what to avoid or different things like that. So, but at least at this point, Congress said, look, you can study hemp, but that's it. But that was a huge stride. So next slide, further research. So what happened was GW Pharmaceuticals in the United Kingdom made Epidiolex. And there were 3 big trials. And it ended up being approved in 2018 by the FDA. So there was a trial in the New England Journal of Medicine in 2017 on Dravet patients. In 2018, New England Journal of Medicine on Lennox-Gastaut patients. And again, in the Lancet Neurology. So once this was approved by the FDA, There was a delay, however, in patient accessibility, because I remember hearing about this being approved and everyone was so excited. And of course, as everything goes, I was hearing about it from my patients' parents first, who were definitely in the know. And by the time we were asking about it, and pretty much nobody knew, like, I don't know when it's going to be available. So what happened was a lot of our states had to change their laws. They had to say that hemp products were okay to use because federal laws are different than state laws. And you can, you have to be within both realms. So the Agriculture and Nutrition Act of 2018 reclassified hemp and hemp-derived CBD products to being agricultural. I mean, I guess you get the job done, right? Whatever you need to do, just get it done and make it available for our patients. But that worked. So again, these products have to be less than 0.3% THC. And they are not under the controlled substances rules and acts, which was amazing because the Controlled Substances Act, of course, are going to limit your availability and use of it, dosage, and who can have it. So the Controlled Substances Act removed hemp from the Schedule I drug list, which is the illegal drug list. And in 2018, the DEA reclassified Epidiolex to Schedule 5 so it can be prescribed like many other medications. This was great as well because when Epidiolex first came out, it was one of the scheduled medications that we had to go through like the DEA, and it was always a special signature and special. And then they changed it to Schedule 5 so we can e-prescribe it or call it in, just like calling in amoxicillin. So it's been great. And this has also helped improve access to care. Okay, so next page, the Epilepsy Foundation, American Academy of Neurology, and the American Epilepsy Society all have a similar general consensus that they support research of CBD and marijuana for cases of medically refractory epilepsy. And if it is used, it needs to be used under close supervision of a physician. So this may be kind of like, well, of course they support it, but this is very important when we look at Congress and the legislature to have these large societies support research because we really do need the research before we can just let everyone have it however they want. We need to study it, and that's going to take time and money, right? Okay. So next slide. The medical marijuana, where are we kind of in 2022? Well, the state medical cannabis laws were not changed by the federal government. So the federal government can make hemp legal, but then now it's up to the states to continue in that form. So 48 states have approved marijuana or CBD for medical use. However, any product which is more than 0.3% THC is illegal, Schedule I class, and the person subject to federal laws and prosecution. So this can be very tricky in these states that allow medical marijuana and have the dispensaries, but yet the federal law is still making it illegal. In West Virginia, we are close to that point, but not there yet. So I'm sure when we are, then I will know a little bit more about those nitty-gritty details. Next slide. So purchasing CBD. So there are state regulated dispensaries of CBD or marijuana. If so, they must follow state rules and regulations. CBD products sold in other places are not required to follow regulations to how it's made, but the FDA can report false advertising. So if you have a bottle that says, this CBD is gonna help you score a perfect score on your SAT. Well, they're going to say that's false advertising, but there's no way that they can regulate how it's made. On the other side of the hemp farms, remember I mentioned earlier that you need a special license and someone will come and inspect it and test it and make sure it's hemp and not THC. But between that and making the product, there really isn't much regulation. So how is the CBD like that you can get at the store different from Epidiolex? I get asked this question a lot. I have patients with epilepsy that are not Lennox-Gastaut or Dravet, and the parents would like to try a similar, Epidiolex. So they will ask me, well, what about this? What about this? The concern about the over-the-counter CBD compounds is that they weren't the ones studied. The Epidiolex was studied. So the ones that you might find at the store have not been studied. So we don't know the effect. We don't know the concentration of CBD based, in that liquid. So, or the milligrams or whatnot. Now they may say it is a certain thing, but that doesn't mean that's really what it is. Another thing is that you may not have a consistent supply of it, or the manufacturer, the company making it might change how they make it month to month, and you aren't aware of that. So when things are made by pharmaceutical companies, there's regulations and quality control, as you guys all know. Okay, so next slide to wrap it up. Marijuana has been used for thousands of years for medical uses. Unfortunately, the THC component can cause happiness, but also poor judgment, anxiety, and dependence, which is what makes it illegal. Separating hemp products containing CBD and less than 0.3% THC from laws about marijuana has allowed new options for medical use for CBD. However, we still need more studies. We need more studies on CBD. We need more studies on THC as well. This came out in April of this year. So the House passes landmark marijuana legalization bill. And you can see it's not really bipartisan, but the House passed this bill. Is not expected to pass in the Senate. And this is actually the second time the House has brought up this bill. The first time it didn't pass, but this time it did. So this is legalizing marijuana. Also in the bill, it will take away some of if you have a conviction or sentence for marijuana use, it will take that away. And so I'm sure that's probably a very sticky situation for the Senate. But I think this is where we're headed. I'm not going to predict or anything, but this is a huge stride that the House of Representatives passed this bill to legalize marijuana. It may not happen now, but it will probably happen soon. Okay, so here is just some summaries. As more states legalize medical marijuana, we will likely see more epilepsy patients self-medicate with marijuana, right? I mean, I get it. You hear that this marijuana helps seizures. I want to help my seizures. Like we were just talking about, I want to drive. I want to be seizure free. I want to work, or I want to get off my seizure medicine that makes me tired and, kind of slow. So, but as we've learned today, the marijuana may help, but it's the CBD in the marijuana that helps, not the THC. So the downside is only Lennox-Gastaut and Dravet patients are approved for Epidiolex. But many other people have other kinds of epilepsy, and they might benefit from a CBD product. Only the Lennox-Gastaut and Dravet patients were studied. So we definitely need more studies on other types of epilepsy. Medical marijuana contains THC as well, but patients may be willing to use this combined product for seizure control. And that's kind of unfortunate, but it's kind of sad that, when states do legalize medical marijuana, say a patient with complex partial epilepsy, they might have an easier time getting medical marijuana than Epidiolex. And that's unfortunate. I feel that's unfortunate. So the CBD manufacturing from hemp is not always regulated, and so there may be inconsistencies or impurities added. We know that as well. But fortunately, it is a popular topic with people, and Congress is being pressured by the voters and are being urged to make quick decisions about regulations. And I feel like these are definitely exciting times ahead for sure. We just need to know more about it. My last page is some really good resources that I found. Of course, the Epilepsy Foundation has a great resource page for medical marijuana. The Brain and Life, which is a magazine for patients made by the American Academy of Neurology, has a nice medical marijuana article. The next one is the FDA, has some nice, it talks about the drug approval process for cannabis products. So that was really helpful as well. Like just to know. I mean, people are really trying, our government is really trying to regulate and do as much as they can. It is nice to see that. The NIDA, National Institute on Drug Abuse, has a nice drug facts and marijuana page. The USDA is now involved because they made hemp products agricultural. So that this link talks about the Farm Bill. The next one, Epidiolex, is from the company that makes Epidiolex. And you have to search pretty far on that website to find the actual studies and numbers, because it really is more of an advertisement. But that is still a great website to look at, lots of patient and physician resources. And then the next one is about Charlotte Fiji, just hearing about her story and what an impact she has made for many children in her short 13 years of life. And then the last one looks at the Marijuana Act of 2021. So any questions? Sometimes I feel like when I do these presentations, it actually raises more questions than answers. I apologize for that, but at least it's a good start of discussion and thought and into how all of this is going on. SEC chat. All right. Well, if there's no questions, then I'll pass it back to Kira. Thank you. There was one comment about marijuana being addictive, and yes, apparently CBD does not have those addictive properties, but I definitely think studying it is what we need to do.
Yeah, you're muted.
So I apologize for that, everyone. Okay, so Dr. Payne, thank you so much. And for all of our presenters that were with us today, I had received a text from someone already saying all of the speakers were awesome, and I think so too. So thank you for joining us. I really appreciate all of your time. Lastly, just to thank our sponsors again for their support. And please, if you have any questions, feel free to reach out to me, and everyone have a wonderful day.